Waliexibok. Good morning. Waliexibok. Good morning. Okay, well, I think we should get our day started before we get too far behind. Pretty excited about the next couple of days. I'm pleased to co-host a follow-up to February's conference. If you remember, in February we did the Justice Conference focused on bylaws and policing. At that time, we asked you a few questions on what you would want this time around. So we've listened, and here we are again with our next session in the Justice Conference. So today, I'm excited to co-host the conference with Annie Bernard Daisley. Where is she?
Right here.
We're gonna try not to run into each other, and we're gonna squeeze back here. I'm sure there's room. But before we get started, I'd like to bring to the stage and Keegan Sack from the Eastern Eagle to open our conference in a good way. And then we will be looking to the Grand Chief to provide an opening prayer. So Grand Chief, after Keegan is done, if I could ask you to come up. Good.
Getting me dead on my edge, start telling yellow thing. They got my start, get my way down it. Getting me dead on my edge, down where the back so thick. They got my start. Getting me dead on my nest, start telling yellow thing. They got my start, get my way down it. Getting me dead on my nest, start where the back so thick. They got my start. Hey,
Well, I'll end you the honor song. Either way, down your honor song. Well, I'll see is not George Paul or New Brunswick. Well, I'll see me. Hey, come down. And get it out. Well, yeah, well, classic. Dan that way, honor song. Dan Delne. Aliam Suti. Thank you for the honor song. I was just saying, George Paul, when he wrote it, it makes our nation use it for healing. I see it all over, and I just want to acknowledge that. And today, I'm here offering prayers for our missing and murdered indigenous people. As we take form, reflecting on their spiritual beliefs and practice to our nation and our communities. A prayer may express grief, seek justice, offer support to the families, while the highlights are needed for healing and reconciliation. So I want to say a prayer. Kisuk, walalia, telmawalia. Keskukon kamla munao. Tandelia, I'm slidai, tancho. Tandelia nuwi, ebijuga, yuajish. Akweji, chiganamina. Eda walia at kunwalien. Tandel ntueg. Tandel nalu si la. Udan menau. Akadawe. Me asud man. Abon winen. Aksit khamu. Tep kunuset. Naguset. Kelnumek me. Asud man. Tanda sapagu nil. Tandil gidnemek. Akamla munau. Tandil gidnema. Edaway. Wala niam sutino. Mizo ami ugap. Tawni genugi. Akadaway. Tepakadaan. Nishkim. Akadaway gisuk. Mea ulin sidwoltinen. Amal gidanen. Ibsidla. Udan menau. Migmagi. Kisiguk. Yuajish. Atawni emudi jugud. Atawni kanalu si. Mudale no giskuk. Amenago wichkuwa. Naliash. Walalio. Thank you.
Thank you, Grand Chief, and thank you, Keegan Sack, for opening us up in a good way for our Nationhood Conference this year. So pretty excited about it. Before we get into it, I'm looking for Chief John Leonard, who is here. Chief John Leonard is a new portfolio lead, and he is our portfolio lead for justice, one of the portfolio leads for justice. So he is the chief that will open up the conference today. If I can look to Chief John Leonard to come and say a few words.
Well, Alia Keegan, Tabayan, Great. Good morning, Grand Chief, Grand Council members, chiefs, councilors, KMK staff, and invited guests. As the co-lead of the Justice Portfolio for the Assembly of Nova Scotia Mi'kmaq Chiefs, I would like to welcome you to the Justice, Mental Health, and Addiction Conference. The discussions and presentations we'll hear over the next few days are a continuation of those started in the Nationhood Conference in February, which focused primarily on justice. Thank you all for joining us here to dive deeper into the work that we will shape our nation's future. This gathering is more than a conference. It's a call to action. It's a space for reflection, sharing, renewed commitment, and healing, and justice for our people. It is essential that we come together to address the shared challenges facing our communities. Just as important, we must create space to hear directly from those we represent, from every community, every voice, and every experience. Over the next 3 days, we will focus deeply on justice and mental well-being, interconnected areas that should not be addressed in isolation. Today, our colleagues from Tajikamic will lead conversations exploring how Mi'kmaq health and wellness are inherently connected to justice. Tomorrow, we will continue discussions on the fundamental principles of Mi'kmaq justice with the team at KMK. We thank both of these organizations for coming together to host such an important discussion for everyone in this room. On the final day, we have invited guests coming in who will not only help to bring everything together, but they will shine a light to reflect how we move forward together as a nation. We are honored to be joined by and hear presentations from elders, knowledge keepers, experts, frontline workers, and those who lived experience. Their understanding and wisdom will guide us as we build a path forward rooted in our culture, our values, and our way of life. Over the next few days, let's listen with open minds. Let us speak with honesty and with the understanding that healing is not a destination. It's a journey we take together. Before we begin, we ask our ancestors to guide us in these conversations. Their wisdom and spirit will lead us to the best path forward for our people. Let us remember that this work and these conversations do not end here. What we share, learn, and feel in this space must be carried back to our communities with action, with care, and with unity. Before we jump into today's sessions, I want to express how much we value the input and guidance of everyone in this room. Your voices are vital to the work of the Assembly and our team at KMK, Tajikamic, and those working to address these issues in our communities. We can't express enough thanks for you all being part of this important dialogue. Walaliak, awalaliok.
Okay, great. Thank you, Chief. And Chief is absolutely correct. We've heard a lot over the years, over the last little bit, Chief and Council speaking about justice and mental health issues, addictions issues in their communities. So these conversations for the next couple of days is absolutely key to get information from yourselves, not only on the challenges, but on the things that you think will help. What do we need to do together? How can we work together to resolve and support not only our chiefs and councils, but community members that are going through the justice system, going through the health system, and we know that both of them were not built for us. They were built, and we were expected to squeeze in. Look at me already going off topic. Sorry, I'm really excited. So Chief Addie's sitting there. She's going to be poking me.
No, I won't.
So before I go on, I'm supposed to do housekeeping. So let's go with the housekeeping. And you could tell I'm really excited about the conference, and I'm really excited to hear your views and your thoughts and what you think is going to work. What do you think is going to work? And even if you're not sure, what are your thoughts? How can we do this? How can we do this as communities? How can we do this as a nation? How can we support each other in this journey? So, Chiefs and Councils, if you did not stop at the registration desk to sign in, I will ask you to do that. Outside the room are our lovely Tina and Chris, who you've seen. So they're out there. Please check in. That's really important administrative item for us, because what we do is we do send travel and whatever directly to the bands. So we have to make sure that you're signed in.
Good morning, everybody. Janice and I will be fighting over the mic the next 2.5 days. Janice was saying that, sometimes she likes to go off on the agenda. Well, I'm the queen of that. So we don't mind doing that. We can poke each other if we go off the agenda too much. I'm also very excited to be here, very honored to be here. And even last night, just talking about this topic, and sorry, Janice, I'll go off a little bit, but just a little bit. When you get together with your peers and your colleagues, it brings out a lot of thoughts and a lot of ideas. And this is what this conference is for, is to really touch on the subjects that we're bringing forth and to come up with maybe some ideas and some solutions that we can all work towards. So, back on the agenda. Also, at the registration desk, they're handing out tickets for door prizes when you sign in. If you didn't get one, please make sure that you got one, because if you don't, then you're not going to win.
And we all love to be winners. I don't care what the door prizes are, it's fun when your number's called. So the next one is addressed to the Grand Council members. Can you make sure, any Grand Council members that are here in the room, can you please make sure to go see Barbara? Barbara's at the coach check-in, so I think everybody does know Barbara. You do have your travel forms that you need to fill out every day, every day, every day. So please go talk to her. She'll help you along with the process. And then we'll get things mailed out. Bathrooms, I'm going to do the bathrooms. I know it says Chief Annie, but it's just one line, so I think I can handle this one. So the bathrooms are just outside of this door. Just go to the left so that you have both the men's and women's bathroom. I'm sure if you go further down the hall, there's other ones as well in case they are full.
Did you do the emergency, Janice?
Nope.
So, in the event that we do have an emergency, God willing, there's so many people in this room that are capable and well capable of handling emergencies. However, there are external doors at both ends of the hallway, at the back room, and in the main lobby in the event of an emergency.
So through these doors and then out that. I feel like the airplane. Through these doors, that way. Okay, so on your tables, now this is one thing that I really, really want to highlight. On your table, you see post notes. Share them among each other. And the reason why they're there is you'll see on this wall over there, our lovely Crystal Vanna is showing you some bigger post notes. And they have topics on top. So the topics of policing, justice, and mental mental wellness. It's still early, not enough tea in me. So mental wellness. So take your post notes. If you're thinking of things, if you have a question on one of those items, if you have a thought, sometimes we don't break enough and we don't hear from you enough. So it's really important that you put down your thoughts and stick it on there. You don't have to do it at the same time. You can, get a pile, do it during the break. But keep your thoughts going, especially when you have panels or speakers. We're trying to do a question and answer afterwards, but sometimes there's some things that you want to take note, and we really want to make sure that we hear your thoughts. So use a Post-it note, stick it on there, stick it on the wall where you think it belongs. If you're not, put it on there, and then we will figure that one out ourselves.
And finally, the discussions over the next couple of days may be heavy, and they are going to be heavy. We want to take a moment to give a trigger warning for some potentially tough subjects. The agenda for the day will be up on the screen when possible, and everyone should have received a copy by email last week. If you find any of the discussions triggering, please feel free to let somebody from the KMK staff know how you feel, and they'll try to get you the support that you need. Or Dodgy Gamic is here as well. And if you just see somebody in the room, you look around the room, there are elders in here, there are people, and mental health support or your peers that you feel comfortable to talk to. Just tap them on the shoulder and ask them to go out, and they will.
Great, thank you. So before we jump into it, I want to thank Annie Bernard Daisley, Chief Annie Bernard, former chief. for helping me for co-host the conference today. We're really excited about it. We're going to go back and forth. We will find our feet beneath us as the day goes on, but definitely thank you for being here. We're excited about it. And then, so maybe I'm going to go to Annie to look at the presentation for the first one.
So just to let, you know, the elephant in the room, you can call me Annie. That's all. Everybody, like everyone's, like, do we call you Chief Annie? Do we call you Annie? Oh, my name is Annie. So that's what you can call me. So don't feel awkward. A lot of people are like, I need to call you Chief Annie. No, you don't. You just call me Annie. That's all. So thank you, Janice, and welcome everyone. To begin with, I'm going to introduce a friend of mine, and who is Nick Phillips, the Director of Mental Health and Wellness and Healing for Dodgegamic. And I'm going to give Nick a shout out and a quote who told me this morning, give me the mic, I have my own bio, I'll do it myself. So welcome, Nick.
Good day, Squidgenog. Good morning and welcome. It's a good day to gather, and it's good to see so many familiar faces. It's been a minute. It's good to gather here at the Ramada, now known as the Delta. So listen, you know, we certainly recognize and hear the voices, not only in this room, but in our community, in recognizing that we have to spend some time talking about the judicial system, to spend some time talking about mental wellness and healing, that it's more than just addictions. And also to talk about justice in self-determination and our inherent rights as individuals who hold indigeneity to place. And so as we built our agenda for the next 3 days, we were really intentional in making sure that it wasn't only an opportunity to share information, but to ensure that we created space and opportunity to have dialogue, to hear and to engage and listen. Because we have a pretty steep path ahead of us, but we'll have really good calf muscles when we get to the top of that mountain. And so we're working towards that. And so we wanted to start our time together in recognizing and certainly acknowledging that, you know, we're in a place now where we have developed an ulnug, amigmal, amigmach, mental wellness and healing framework that was designed by us for us and will be implemented by us without any outsiders dictating what we can and cannot do. And so that's something that we have to recognize and celebrate. And so in our first presentation, as I lead us through this day, is that I want to spend some time to talk about our mental wellness and healing framework that we were able to release in the fall, where we had the opportunity to present it to health directors, that we were able to bring Sahamah together and share with leadership, including our Sante Mawiomi, to ensure that what we're sharing makes sense, that we see ourselves in this plan, and that we recognize the complexity of all of the work that we have to undertake and do. And so to Annie's point, when they reached out and they said, Nick, we need a bio, I said, it's not my obituary, so just hand me the mic and we'll be good. So for those of you that don't know me, my name is Nick Phillips and I come from Millbrook. And I am with our Dodgegamic leadership team leading this mental wellness and healing framework as the Director of Mental Wellness and Healing. And so over the next couple of slides that I'm going to share with everyone, is to actually talk about our framework, how it came to evolve, what we've collected to ensure it is added in there, and to talk about high-level pieces of some of the things that we're doing right now, that there are things right in this plan and this framework that are being implemented at this moment, and of course the ripple effect as we patiently wait with Dajigamik's transformation. And to also, again, to take a moment and to acknowledge that we, as our communities, representing part of the Mi'kmaq Nation, are going through health transformation, that we are going through the process to reclaim and assert our right and our self-autonomy in our health system so that we can develop a system that is equitable and accessible and inclusive and free of anti-racism and discrimination against our community members, including ourselves. And so there's a clicker here. This one looks like a little cell phone. All right, here we go. Oh yes, perfect. So one of the things that I wanted to share is the purpose and the vision of our framework, in saying that this framework and the purpose is to create and maintain an environment where Ulnug, all of us, have equitable access to the resources and opportunities to support our wellness and our healing through a culturally relevant, holistic with a W, community-centered ways. That our framework is not only to address the compact trauma that we experience on a daily basis, but it's also to address the intergenerational trauma. It's about revitalizing our cultural practices, that we're accessing land and water for healing. And that in some ways, we have to have two-eyed seeing, that we have to recognize the benefits of both worlds and how we can blend them together. And so our purpose and our vision is to guide those ongoing efforts in mental wellness and healing, aiming to close those health gaps between Ulnug in Nova Scotia and non-Indigenous Nova Scotians. What's important is also acknowledging that we've done our due diligence to make sure that we looked at international laws and regulations like UNDRIP, that we look at the national level when we're talking about the calls to justice around our missing and murdered Indigenous women in Edidwi-Jijakamijinug, that we're recognizing the 94 calls to action, that we're also taking into consideration understanding around Indian day school and Indian residential school settlements, but also holding the province to task in recognizing that if the province has an equity framework, well, then we better be showing up in that framework. But just as important with the international, national, and provincial work is to also acknowledge all of the stories that are happening and being shared in our communities, in understanding what our community members are sharing. And so in developing this plan and this framework, we've engaged our health directors. We've engaged our leadership. We've engaged our Sante Mawiomi. We've also done our due diligence in ensuring that we've gone to all 13 of our communities, including the Mi'kmaq Native Friendship Center, and have housed and hosted Mawiomi Jijas to have meaningful conversation from community members to ensure that their stories are heard and listened to as we build this plan. And so over these next couple of slides, I just want to share some of the things that we've gathered from community. Now, I won't read it verbatim. There's a lot of words, so we know that this was sent out in your email, so print it out, read it, enjoy it. It's a good read. But these are the important things that are standing out. That culture, community, and language has to be the foundation of our work. That the practice of culture and ceremony and language, along with community gatherings and physical activities, are important for wellness. That when we're creating literature and documentations and sharing of information written in text, that our culture and language has to be embedded in that. And so as an example, one of the things that we shared on everyone's table is a smudge card. And these smudge cards were developed by our Dudgeygamic team to not only share the process of smudging and what it entails, but it's a tool that we're able to share with those that are visiting our hospitals and our communities as they reclaim the ceremonial processes of smudging. And so it's a resource. That's simple. That's accessible to all of you in this room. You just have to reach out. We also say that we have to improve access to mental health and addiction services, that it has to be more accessible, that there's way too many barriers that are in place right now, whether it's through withdrawal management, detox, treatment, aftercare, return to home, one-on-one counseling, traditional access to our traditional healers, our elders, our medicine people. But also in recognizing that we have to bring our community members and our families and our people back to the land and to the water. That it's about Giduapsim, that we have the ability to survive and that we're able to reclaim that. We also have to recognize that our suicide rates in our communities are really high, and so we need to address that. We also have to address the diverse needs that are showing up in our communities, that autism, neurodivergent, that our programs are not a one shoe fits all, that just because we're Ulnu or Mi'kmaq that it's going to work. But in fact, we actually have to create programs and services specific for our demographics. That our Eduiji our true-spirited people have programs, that our women have programs, that our families have programs, and our men and our youth, but also our elders. Who's checking in on them to make sure they're doing okay? We expect a lot from them, but where's the reciprocity? Also recognizing the determinants of health, that physical activity is important, but so is food. Food security and food sovereignty. And that the environments that we show up have to be culturally sound, and that they have to work together. Community is also saying that, you know what? We need to have culture in the mental health and addiction care. That when I go to Nova Scotia Health or I go to see a clinician, I should be able to have medicine right on the spot. I shouldn't have to wait for them to go through their rubric and their protocol to shut down their buildings, to shut down their airways, to shut down everything, to call the fire department, just so that I can light sage. What do they think we're going to do? Burn the place? It's not a bonfire. So it's teaching and expanding that capacity and understanding. There also has to be transitional support after our addiction care. That if community members are leaving and they're coming back, what's the wraparound? What's the extended support that we know that after 5 weeks of treatment, it's not enough? And so what are we doing to ensure that we're continuing on from start to finish? Also, in recognizing that there needs to be an expansion of our addiction services, that it doesn't have to be linear. It doesn't have to be one way. And again, as Dajigamic moves towards health transformation, we will be able to get to rewrite that. We will get to be able to determine what's best for us from start to finish. But also acknowledging that a really big area of our plan and what community is saying is that, you know what? We need to stop sending our youth out of Mi'kma'ki for treatment. Our youth should be able to stay here and receive the treatment and the same type of care, if not better. And so those are the things that we hear and acknowledge. Part of our agenda over the next 3 days is to also create space and opportunity to start talking about policing, specifically around wellness checks, that those wellness checks aren't working, that in fact they create more harm. And so from our point of view, it's saying, you know what, we have to have a deeper conversation, because why are the police even showing up in the first place? What system can we create to ensure that the right individuals are showing up in that time of need? It also means that we have to create spaces and opportunity to talk about our crisis, to talk about a crisis line, and creating pathways so that when community members call 811 or when they call 911, that we as community members and as a system are aware of those calls that are coming in. It also means that we have to address violence: physical, mental, emotional, spiritual, domestic, partnered, gender-based violence, sexual exploitation, and human trafficking. That's all part of this. And again, it's also addressing the diverse needs of those vulnerable populations, that as we create programs and services in partnership with our communities, that, again, it's not a one-shoe-fits-all, that yes, we'll have programs and services, and we'll have programs and services distinct to those populations and those needs. Our parents, our women, our men, our youth, our elders, our Two-Spirit. And so those are the things that we've heard from community. Those were their top priorities. Those are the areas that we need to address. Those are the things that each and every single one of you in this room have fed into. And so in knowing all of that knowledge and all of that information, we developed guiding principles that says, you know what? It has to be two-eyed. That it has to be Dajigig. It's about wellness. That it's strength-based. That it's human rights and indigenous rights-based. That it's about capacity building. That all of these movements and all of these positions that we move should be housed by our community members. That we need to address the white savior effect. And these people that think that they know how to do best. Yes. Hand me the mic. Mic drop. And so in that means that it expands further. That means that we look at our minds, our Mi'kmaq and Indigenous nurse education specialists who are working to ensure that Mi'kmaq are becoming nurses, that we are creating pathways for them to do that. That we have worked and developed the Bakjigina Malsudi Dalgina Mujik Mijuajish, the Mi'kmaq Early Childhood Education Program, that we have the Umsit Mijuajij program, the home visiting and intervention, because that's where it starts. It's stronger to build strong, resilient, proud Ulnu children than fixing broken community members that don't have that sense of identity. And not to let the cat out of the bag, but I'm going to let it out of the bag, that we're working to develop a Mi'kmaq Masters of Social Work program that will be embedded on the land from a Mi'kmaq Ulnu perspective. And so we'll have Mi'kmaq social workers that don't have to travel out of Mi'kma'ki to be educated. We're already educated. We just need that paper. And so, in acknowledging all of this, what we've done is we've organized it in a very simplistic and visual way. That when we think about the way that we're going to approach this framework, it's going to be done in 4 areas. And regardless of how they're done in those 4 areas, the main thing is that the Ulnug, us, are at the center. And keeping us at the center means that the wraparound is start to finish. And so how we've categorized this piece and how we've broken it up is we're saying, you know what, it's more than prevention. That it's Niganidasim. It's about forward thinking. It's about what we do today has its outcomes for tomorrow. And so this is about thinking ahead. This is about prevention and engagement. That if Dajigamik is that tense of we're working towards wellness, well, what happens when we get there? What happens when individuals are well? Well, we have Dajigayamk. And this is where our programs and our services and our maintenance is happening. And so we're super excited to welcome our Blossom Labilawa, who's joining us as our Dajigayam coordinator, who is going to start some of this work. That we're developing a life promotion program, i.e. suicide prevention. That we're working at creating our human trafficking table. That we're working with our health directors and Feed Nova Scotia to bring food into our communities without the need to collect data. Whose data? And for what purpose? People are hungry, we already know it, so give us the food. But also balancing it with our traditional foods, because who's to say that colonial food is better? That we have to be able to reclaim that traditional harvest and that traditional medicine. And so when individuals are not in a state of dajigeg, that they are well, is that we have nebi sultim, which means that we're healing together, that it's not individual, that it's a commitment together. And to wrap that all around into Sweetgrass is say, you know what? It's about cultural quality and safety, that we have to have infrastructure and capacity, and we have to build our workforce. So let me break these down just a little bit more, okay? When we're talking about Niganidasimk, our goal is to strengthen Ulnuidasimk, ensuring that everything that we offer has culture and language embedded in it. That we're not going out on the outside and we're taking and adopting things and then adding a little bit of Mi'kmaq flair to it and calling it a day. We're going to create everything from the ground up, and we're doing that. And so Niganidasimk is about prevention and safety approaches that recognize Ulnu's strengths and our needs. It's about building capacity for cultural responsive interventions that integrate culture and language. So I'm not going to go through this in crazy depth because, again, you would have received this copy. But essentially, everything that we've heard, from addressing suicide, from specific targets, from creating a wellness circle and bringing like-minded individuals together, that's all the work that falls under Niga Nidaasim. So when we talk about Dajigamk, that it's more than prevention and it's more than engagement, that now we're in a place of wellness, means that we're working in partnership on wellness with our Ulnu communities, that we're working with our elders and our knowledge holders and our traditional healers. We're working with our Mi'kmaq partner organizations like Mi'kmaq Ginamatnue and our local schools, that we're looking at Indigenous Early Learning and Childcare, IELCC, Aboriginal Head Start, METS, all of those educational pieces. Working with our partners at the Confederacy of Mainland Mi'kmaq and Union of Nova Scotia, Mi'kmaq. That we're working with the Mi'kmaq Native Friendship Center and the Wabanaki Two-Spirit Alliance and Native Women's. And so in this work, we're talking about community environments that support wellness and safety, that we're expanding our high-quality services, that we're creating access to the land for wellness for adults and children, for youth and families, that we have access to enhanced wellness programs. So as an example, it's our hope that Dajigamik will become like a sister partner to the Thunderbird Partnership. And instead of going to the Thunderbird and Borolindur Buffalo Youth Program, well, we don't have buffalo here. So what are we doing? We're going to rewrite it so that we have our own programs and services that can be accessed by community. That it's also about addressing our biggest area that we've heard from leadership and saying, you know what, we need to focus on our youth. We need to focus on youth mental health. And so we're doing that. So when individuals are not well and they need healing, what this means is that Ulnuk have access to healing services that support a return to wellness. Meaning that our healing actions are intended to be implemented by working in collaboration with our Ulnu communities, with our elders and our knowledge keepers, our traditional healers, with Natica, and all of our other partners. That it's not done in isolation, that we're doing it together. What this means is we're prioritizing access to detox. We're already in conversations with the province and saying, you know what, we need designated beds. That if that's a barrier to get people into treatment, and detox is an issue, you need to deal with it, because now we're here and we're telling you. But it's even pushing it further and saying, you know what, we need Ulnu staff in those detoxes until we get to a point where, you know what, we're going to open our own detox. We're going to open our own program. And so we're in partnership and conversations with our families out west who are developing a detox program directly on the land. And so how do we bring detox and withdrawal management back through ceremony and land? And so we're working on that. It also means that we have to have a crisis response, which means we have to stabilize the Eskasoni crisis line and expand it to ensure that it's accessible in all of our Mi'kmaq communities. That wellness checks are a top priority. We're gonna work on that. We're gonna create a system to ensure that when wellness checks are triggered and one needs to be responded on, is that we have due process and that there is capacity and understanding in all 13 communities on how that works. And so to protect and to maintain the quality of those three areas is where we get into that sweetgrass and that medicine and saying, you know what, it's about cultural quality and safety. which means that Olnuk have access to high quality and safe wellness systems, that Olnuk have access to high quality, safe, and culturally respected care. And this involves creating a healthcare environment where traditional healing practices are honored, where indigenous specific racism and discrimination are eliminated, and that our services are trauma-informed and holistic with a W. What this means is that working with Nova Scotia Health and IWK to create pathways so that when our individuals are showing up, we have immediate access to ceremony, we have immediate access to supports that are culturally safe and trauma-informed. It also means that we have to address the Nova Scotia Health and IWK mental health and addiction services and their environments, and we're doing that. It also means that we have to build capacity within our communities, that we have a lot of knowledge in our communities, and that it's not just conditioned to this colonial concept of education and those parchmen. That we have to look within ourselves and acknowledge all of the good medicine and all of the good work that is happening, and amplifying that and celebrating it. It also means that we have to have a clear pathway where we acknowledge our elders and our traditional healers at the same level that the colonial system acknowledges clinicians, that there is no difference. It means that we also have to address the infrastructure, that our communities deserve youth spaces, that our communities deserve healing spaces and wellness spaces to offer programming, that we have to have withdrawal management and a recovery and a return to home system that's supporting community members when they're not ready to return back to house after coming from treatment. It also means that we have to look to a youth mental health and addiction treatment facility. That again, we have to stop sending our little humans out of the province. Because frig, that's scary, especially in the climate that we're in now. As parents, who the hell wants to put their kid on a plane and be like, all right, I'll see you in 5 weeks? That it has to be holistic and connected. One of the things that we're working on right now with our partners at MKK and Mi'kmaq Family and Children's Services and Dudjagamic is we're working to open a Mi'kmaq youth house so that youth that are in care have a central location or an opportunity to be centralized where they can receive the programs and services that they need. And finally, it means it's about cultural quality and safety, which means that we have to develop in pathways for training, that we have to bring training and learning opportunities to community and not rely on outside organizations or other Indigenous people to come and tell us how we should be doing things. That we are going to develop it for us, by us, and be implemented by us. That our mental wellness team at Dudjagamic envisions having facilitators, educators that will travel throughout community offering programs and services not only to staff and healthcare teams, but to the community. Like grief and bereavement. That there are pathways for healing through ceremony and healing through loss. That we don't have to look to hospice society or palliative care or the grief and bereavement team at the province. We know how to do it. We've been doing it for 13,000 years. And so that's what we need to honor and acknowledge. And so what I share with you is that it's a big document. It's 30-something pages. I just threw a whole lot of information at you. But I think what's important is acknowledging that, you know what? It's ours. It's our plan. It's our framework. It's been created by us, and it's going to be implemented by us. And change is happening. And so, as we start today, we were really intentional in saying, you know what? Rather than jump into the research and jump into all of these other pieces, let's just take a moment and acknowledge and celebrate the fact that, you know what? We have a framework, and we have all of those pieces that are popping in your mind, that we're hearing in community, that we have an action item. That again, as we all acknowledged this morning, that healing and mental wellness is not a destination, it's a journey and it's a commitment. And we're going to work really hard to make sure that people see themselves in that journey. So the canoe is in the water. We're not going to let it sink. Tahoe.
Oh my goodness. Just speaking from the heart, I always like to speak from the heart. I just want to thank you, Nick, on behalf of the Assembly of Nova Scotia Mi'kmaq Chiefs, Songmouse, that I think we're all blessed to have you and your team and all the work that you do. The future, I look as a mother, I'm going to speak as a mother, that just very proud of everything that you have presented. So on behalf of the Nova Scotia Mi'kmaq Chiefs and the Assembly, I'd like to present this as well. Awesome job. Yeah. Awesome job. Phenomenal. So with that, we're going to call for a 10-minute break. And I'm going to just say, like, 10 minutes is 10 minutes. As you know, I was co-chair of the Assembly of Chiefs, and I kept everything on time. So 10 minutes is 10 minutes. Janice, what time is 10 minutes? 11 o'clock to be back. Around there. 11-ish. Yeah.
All right, I'm just watching Nick walk around the room, but I know the next section is his. So I'm going to ask everybody to find your seat, please. We'll look to get started. That's the risk of going on break, is to be able to bring everyone back to the room. Would like to have the room's attention so we can get to our next agenda item. Thank you for that. So thank you very much, Nick, for your conversation this morning. We worked really hard with Dejagamic and other groups to put the conference together. So I'm going to ask for your attention, please. And just so I know there's going to be chitter-chatter through the room, I'm going to ask you to keep it at a minimum. And if there's things that you want to, again, there's the sticky notes. Please use the sticky notes. And then if you need to go outside of the room to take a phone call and whatever, that's great. But just wanted to make sure for those individuals that are here to participate that they're able to hear the presentations. So I do want to take this opportunity to thank Dejagamic and Nick for the presentation earlier. It was really nice to hear what they're doing. It was really heartwarming to know that we have a framework and that our Mi'kmaq organizations are working and we're all on the journey. It's nice to see that we're on this journey together and that we're working together. That's one of the things the challenges that we had in the past is a lot of the organizations didn't coordinate and align. And now we're working towards that, and that's very exciting. So how we support each other, how we work together to, I guess what they say is high waters floats all boats. So how do we do this together? And it truly is a governance issue. It's how the leadership of Nova Scotia Mi'kmaq, not only chiefs, but chiefs and councils, look at their organizations to do the technical work, to come together, to come to leadership with hopefully some solutions, some programming, and not only look at short-term, but short, medium, long-term solutions, and actually walk on that journey. So thank you, Nick and Dejagamic, for being here with us every step of the way. And Chief John said it earlier, we're pleased to work with them and their great input over the over the next couple of days. So the next part on the agenda, Nick is going to take over the panel discussion. And I'm going to invite him back to the podium to get started on his first panel, focus on prioritizing wellness for Mi'kmaq youth. I see Lindsay over there, and I just want to do a shout out to Lindsay. So thank you for all your help in working with Dejagamic over the last couple of days, and I look forward to working together, especially on governance issues, the governance, health, wellness, addiction, and justice issue. So when you're thinking about this, truly think about it as well as us, the Mi'kmaq, taking control and taking action to help support our own communities. So with that, I'd like to welcome back to the podium, Nick. Your things are down there, and you're the one that's going to give them.
All right, perfect. Thank you for that, Janice. Like I said this morning, just hand me the mic and we're good. So keeping that good intention going and knowing that we have a framework, we're having a lot of really good conversations. We know that youth mental health and wellness is one of our top priorities. And so we've invited several individuals to join us today to talk about some of the things that we're seeing in research, in qualitative and quantitative methodologies, but to also invite our friends at the Canadian Research Initiative around substance matters as the Atlantic node, and also knowing that Dejagamic holds a seat at that table when we're talking about research and substance matters, where we've had the opportunity to travel recently back in May to Banff and spend an entire weekend together with Indigenous groups and parties and individuals who are doing amazing research and work for their communities. And so, with that being said, I would like to invite Dr. Phil Thibault, who is with the Department of Psychiatry at DAL and as well as Nova Scotia Health, and the research that he's currently doing. We've also invited Dr. Celine Etches from the IWK, who specializes in adolescents. And for our CRISM friends and partners, we invite Sherry Stewart, who is our lead investigator. And we also have Renee Mashing, who was the Indigenous coordinator prior to Blossom, where Blossom has now left them and has joined Dejagamic. So we're taking all the good humans to do a lot of the good work. So with that being said, I'd like to invite those four individuals to come forward and to share some of the important information that they hold today.
Good morning, everyone. Privileged to be here. Just waiting for some slides to come up because as an academic, I can't speak unless I have slides in front of me. So very much privileged to be here. Thank you so much for the invitation. Just a little bit about myself as well. So I am a psychiatrist, and I'm a professor of psychiatry as well. So I work with youth and young adults, primarily in early intervention services, and also a researcher too. And most of my researching is focused on the youth and young adult population with respect to psychosis and early intervention services. And one reason I was asked to be here is that a lot of my work is involved with comorbid substance use, and in particularly cannabis use in our youth and young adults, and that as a risk factor for development of psychosis. So that's just a little bit about myself. Obviously, I'm here and I recognize and pay respect to the First Peoples in whose territories I live and work. And of course, I work at, as mentioned, at Dalhousie University, but as well at the QE2 Health Complex as part of Nova Scotia Health. So just to get started, I was asked here to speak around cannabis and mental health, and particularly around psychosis. And I thought I'd frame things up this way initially, is that really what is this conversation and discussion? And really it's about having this conversation to give the information to our youth and young adults so they can make informed choices, right? So there's a lot of research going on in this area, but it's important for us to get that information to the youth and young adults so they can make the right choices for them. And I put it there what it's not. This conversation is not about that sort of total absolution, don't do drugs kind of approach. And I put two examples there of kind of substance use campaigns that probably we say didn't really work because that was their approach, right? So really my approach to this is, look, this is the research, this is what we're finding. We have to get it to our youth and young adults so that they can make their choices and for healthy life. So that's sort of the context of things. And just a few points to start off with. Many of us know this already. In Canada, the federal government legalized cannabis for medicinal use in 2001, and then for recreational use in 2018, followed in 2019 with edibles and topicals as well. And I thought I'd throw this up here as well. So this is actually where we are globally right now with respect to cannabis legalization. As you see, it's mainly in Western North America that we see legalization. And in the US, it's really dependent on each state. And there's a few other countries in the world that have legalized as well. But we also have jurisdictions and places where it's not legal, but they've decriminalized it, which means that if you got caught with it, it's like a fine, like a parking fine or a speeding fine, but it doesn't go onto a criminal record. But as you see, a majority of the world still is within, consider cannabis use illegal. And I guess a couple other sort of grounding points to start this conversation as well. I just want to jump into the whole conversation around sativas and indicas with respect to cannabis, because that's a lot of the conversation. Any of our youth and young adults go to the stores, the outlets. There's that great conversation. Oh, what are you looking for? What's better for the sativa or the indica? One's supposed to be more, a little bit more mellow. One's supposed to be a bit more activating. Just to say at the start, I'm not really sure if this is the information or how we should approach getting that information to our youth and young adults around the cannabis plant itself. Sativas and indicas, yes, they're two different plants, because they came from different parts of the world as well. They look different, and they do initially have different properties. But what's happened over the last number of years is that there's been this, the cross-pollination, the interbreeding of the plants. So most of the plants out there now are just hybrid. And there's actually, we've done research that shows that, there's really no difference genetically in the chemical makeup of these plants today. So they are more alike today than they have been in the past. But I say that because I want to move away from thinking about sativas and indicas. Really, what we need our youth and young adults to know about is around some of those chemical constituents, the makeup, what's in the cannabis plant, and that's around THC and CBD, right? So tetrahydrocannabinol and cannabidiol as well. So I think that's really a good education if we can get people to start talking about the THC and CBD of what they're using in the products versus, is it a sativa and indica, right? Because as you find, as I continue to talk, you'll hear that this is really where a lot of the science and research is around THC and CBD, both negative sort of outputs from that as well as some positives as well. So that's what we'll talk about. So I put here, I'll ask you a question here as well. What currently do you think are the most common methods of cannabis use in Canada? Sometimes pretty obvious, but any thoughts? Sorry, I'm going to stare at people until you answer. Smoking and edibles, yeah. And I think that's, from our Canada Cannabis Survey last year, so this is asking people what they use, not necessarily data from outlets or stores. And what we see, again, those first three major ways of using cannabis shouldn't be a surprise, is smoking, using that dried flower, the edibles, and those vape pens and cartridges as well. But what you see is that we've seen a difference in the last 5 years since legalization, is that the vape pens and cartridges are going up. They weren't really available back then, so they're definitely becoming more popular with our youth and young adults, which is an issue in itself because that's a higher potency product, and we'll get there. But edibles are up as well, but still smoking is the most common. And I put some interesting data there as well, because people ask about pre-rolls. You go to the store and you get pre-rolled cannabis joints. Really only about 20% of the population, this is all age groups, this data, only about 20% just buy pre-rolls. The rest is a bit of a mix when it comes to the dried flower and products. But how about use with tobacco and alcohol? Do you think it's common to use cannabis with tobacco? I just see some head nods, yeah, and with alcohol as well. Interesting, I asked this question to grade 12s. I had to do 2 lectures to grade 12 biology students last Monday, and I asked them this question as well. They were actually surprised with this numbers. And sorry, I have a few graphs in here, but I'll walk you through them. And really what this is showing that, on average, and again, this is all age groups, that around 40% of individuals will use cannabis in conjunction with alcohol use as well, right? And you see the data there, around 25 to 30% will use with respect to tobacco, right? Either mixing it or at the same time. The grade 12 students I talked to last week actually thought that number was a lot higher, right? So I think if we broke it down by age group, we'd see differences as well. But just to put that in there as well, because of course, co-use with alcohol and tobacco, implies some increased risks as well in other ways. But then, how frequently are we using cannabis in Canada? And this is a good one. I think usually I ask that question, people just say a lot, right? And yes, historically we have been using, even before legalization, we've been using a lot of cannabis. I put some numbers here too as well, is that it's also our youth and young adult population that have been using a lot of cannabis. And you see some stats that perhaps aren't that great for us to be proud of necessarily, that almost 1 in 20 are using, of our youth, are reporting use on a daily or almost daily basis for cannabis. And actually, when I have the conversations around which province has the most cannabis use, a lot of people go with BC, but it's actually here in Nova Scotia. We have the most cannabis use out of all the country. It's not significantly higher BC, but a few percentage points higher. So there's a lot here. There's a lot in Canada. I also show some data there in that box because people ask, well, what happened with legalization and use? And this is just like use in the past 12 months in those first 5 years after legalization, but broken down by that 16 to 19-year-old age group and that 20 to 24-year-old age group as well. And what you see is that it did increase, the use did increase, but it didn't skyrocket, right? So legalization didn't cause this mass necessarily flooding of increase of use. It went up a little bit and it's kind of come down and stabilized a little bit, but at the same time, look at those rates, right? The numbers and the percentages, they're still quite high, right, for these age groups. And if we break it down into this just kind of carries out a little bit further. I'll just say that if you look at that top line, that blue line, that's age group of 20 to 24. That's still hovering around, like use in the past year is around 50%. And the next age group, though, with the most common is 16 to 19-year-olds, and that still remains around that 40% line, right? I look at that and say, okay, those still are numbers, high numbers, but this is kind of past 12 months, how concerned necessarily, especially in the 16 to 19-year-old age group, how concerned are we with that? I think still more concerning is this daily or almost daily cannabis use, right? And here, I know these lines are a little mixed up, but if you go just to the year 2024, you'll see that 20 to 24-year-old age group, Daily or almost daily use is still around 25, 27%. And daily or almost daily use in our 16 to 19-year-old age group is still around that 20%, so 1 in 5, right? Which is still, it's pretty significant. And I think we had that conversation around alcohol use. You know, we'd have some concerns that would generate its own discussions as well. But and that's been fairly consistent, which is quite interesting. We haven't seen a decline as well, or incline. But still around that 20% of our 16 to 19-year-old age group are using on a daily or almost daily basis. So then this comes to this question, well, why are we concerned with this, especially in a younger population, right? Why are we concerned with cannabis use? And usually what the number that you hear is below the age of 25, right? And that's really what I want to mention today, and I do apologize. I have to go into some little bit of science here with respect to this, but it's important for us to know that we're not just making this up. I mean, we do have 30, 35 years worth of research in this area to be able to say that, you know, we should be concerned with these rates of use in our young population, right? And this comes down to that as humans, we have what's called an endocannabinoid system, right? It's an unfortunate name. I always put that out there. It was named the endocannabinoid system, mainly because in the 60s and 70s, they're trying to figure out how cannabis works on the brain, how it influences on the brain. So all those parts that they found, then they just named it endocannabinoid. I have young adults that I see that say, hey, we have an endocannabinoid system, so we're supposed to be smoking pot. That's not the reason. That's not the answer. It's just a bad name, right? But this is where THC and CBD has its influences in this whole system, right? So we naturally have an endocannabinoid system, and yeah, I know, lovely diagrams there. But just to mention that, you know, we've got receptors in our brain where the endocannabinoids bind and where THC and CBD bind as well to exert its influence, right? These are the cannabinoid receptors. We have two types, mainly CB1, CB2. CB1 is mainly in the brain. CB2 is in the brain, but mainly outside the brain as well. And we have those receptors. Then we have those endogenous sort of chemicals that bind to those receptors, right? That's just a part of who we are as humans. But it's involved, this whole system is involved in a number of different processes. And that includes, you know, as I mentioned there, pain processing, emotional regulation, memory and learning. But importantly, this endocannabinoid system is involved with brain development as well, right? So that's what I'll just focus on. So again, we have an endocannabinoid system. This is where THC and CBD influences, and we know how that all works. And I just mentioned, yeah, so very important, the specialized role of this system in all phases of brain development. So from gestation, baby, up until that adolescent time period, right? And young adulthood. So that last phases of our brains to develop is that late adolescence to early adulthood. And usually what we say is that, you know, you're at 30, you kind of got the brain that you've got. Nothing's going to change after that. But up until that, there's a lot of processes that are happening that allow that brain to mature, making its right connections, you know, the neurons getting to the right places as well. So that a lot of that final phase is in adolescence and young adulthoods. And we see that, just to mention, because in adolescence, those natural endocannabinoids, they're at the highest peak. After adulthood, they go down. And also those receptors, those cannabinoid receptors, CB1 and CB2, they're at the highest amount, highly expressed in adolescence and young adulthood. And again, they change and they go down when you get older, when you move into past 25 and 30 as well, right? So just to underscore, this is a critical sort of period of brain development, those last maturational processes. So then we also have to consider that as a period of vulnerability as well, right? And really sort of the two messages from the biology behind that, I know I just sort of whizzed through that, but really the message here is that the effects of cannabis on this young age group, because of that biology, is significantly different from the effects that would happen when you're a bit older, 30 plus, right? I always say, and I know I say it facetiously, hey, if you're 40 plus, smoke your heads off, I don't care, right? But when you're younger, you know, just be mindful of what some of the negative outcomes could be. I say that, but yes, there are effects if you do smoke your head off past 40. So, but we also have this biological explanation. We can show biologically all the differences and things that are happening within the brain, both gray matter and white matter, because of cannabis influences as well, right? and the resulting, what can happen when you have those changes in brain structure and function as well. So that's just to say that's why we're focusing on this young age group and those effects of cannabis. But then it comes down to, I'm here, I was asked to speak to run that link around cannabis and psychosis. But as well, it's important for us to have an understanding of what cannabis use patterns cause the most risk. Because I think that's the important information that our youth and young adults should have. It's not about use or no use. It's about how they use that may infer higher risk. I thought I'd step back. Again, I was asked here to talk about psychosis or psychotic disorders. I'm not sure how, people's knowledge about psychosis and what psychotic disorders are. That's a whole other lecture series that we would give to our residents and experiential learning as well. But just to say that, the psychotic disorders that we have in mental health, they can be quite debilitating to youth and young adults. World Health Organization has called, psychosis and schizophrenia, youth's greatest disabler. Significant effects on functioning, a lot of, cost and burden to the families, the individuals, and to communities and society as well. And most people know of psychosis around certain particular symptoms. You can have those delusions and hallucinations. That's not a part of the culture as well. And as a result of those delusions and hallucinations, may be acting in certain ways, but definitely affects functioning, cognition, a number of different areas. So what's this risk, right? Cannabis and psychosis, kind of what it coming down to. A lot of studies that have looked at this. I put up one here, an older one, but it's been replicated a number of times, just to show. And this was the Swedish conscript study. So in Sweden, everybody get to 18, you're conscripted into the army, right? When you do that, they do a lot of rating scales and assessments. And they were able to show in over 45,000 individuals, if you're smoking cannabis by that age of conscription or 18, you're about twice the risk of developing psychosis if somebody wasn't smoking cannabis, right? So about twice that risk. Again, that's been replicated. They were early enough early to show that, if you're using more, you're going to increase that risk. So it's not just are you using or not, it's just the amount of cannabis that you're going to be using that can increase that risk of overall development of psychosis. But I go, well, okay, that's great, but we also need to know more around this. And this is sort of the work, sort of a slide that gives an example of the work around that age of use or that age of first use and how it can influence psychosis development too. This is an interesting study. This is a group in New Zealand. They've been following over 1,000 individuals from birth, and these individuals are now in their 50s and 60s, and looking at different time points and doing different evaluations. And here they evaluated their drug use at age 15 and 18, and then also when they got to the age 26, interviewed them to see if they had any mental health issues. And so what they looked at then, cannabis use by age 18 and cannabis use by age 15. So cannabis use by age 18, and if they then developed a psychotic process, that risk was around twice the risk, right? So basically just replicating what we've seen in a lot of the other studies. But what about that users by the age of 15? Do you think that risk goes up? See some head shakes. By much, do you think? Yeah. Well, in this particular study, the risk went up to about 11 times that risk compared to twice the risk, right? So this just, again, underscores the biology. That's 15 and 18. Only 3 years difference, right? But that, again, illustrates the impact that THC and CBD can have on this endocannabinoid system during this age group, right? So that's age of use or age of regular use. What we're seeing as well is that I mentioned that average age of development of psychotic disorders is late teens, early adulthood. What we're also seeing is that cannabis is actually lowering that age of onset of illness, right? And Salim Dr. Etcha, may talk about this later as well, is that we're seeing more younger people develop psychotic disorders and because of cannabis. And why is that significant? Well, I think with anything with health, right? If we get an illness earlier on, the outcomes are harder, maybe more negative, harder to treat, more negative outcomes, right? And of course, something like an illness like this, you don't want somebody young to get an illness because there's a lot of things that need to go on to get them to get better. So, but we've seen this, that age of, the age of onset of psychosis is decreasing because of psychosis. And we've also seen it decrease too because of potency of product, right? When I say potency of cannabis, people are aware kind of what I'm talking about, and that's the THC percentage of the product, right? But what we've seen is that THC of plant go up over the last number of years. I always ask the question, what do you think is the normal, natural THC percentage of a cannabis plant? Any thoughts? Oh, you were answering questions earlier. What do you think?
What is it again?
There you go. I say the natural, well, the THC percentage of natural cannabis plant. I heard 10%. 20? No, the actual cannabis plant is only about 1 to 2% THC, right? So in the 60s and 70s, if you were smoking back then, it was only 1 to 2%, 5% THC. But what we've done, we being humans, is that we've genetically modified this plant over the years, so now it's considered normal for it to have 20 to 25% THC, right? So our youth and young adults are actually using a product that's completely different from even 10, 15 years ago with respect to potency. And that has a definitely bearing on this whole endocannabinoid system and brain maturation as well, right? So that's something to consider is the potency of product. And I put here, has then this high potency product affected psychosis development around the world? And yes, like I'll just say is yes, we've seen this. Those centers around the world that are using more significant high potency product have the highest rates of psychosis development, right? And we see that high potency product versus low potency product, significant difference within psychosis risk. Now, I was talking about psychosis particularly, but also keep in mind there's an analogy here. There's not as much research yet, but there's an analogy here with the development of anxiety, depression, suicidal ideation with this as well that goes along that too. So high potency product is a big concern for us, and we're seeing it clinically as well, the effects with people that are coming to us and how the illness is being expressed and how we can treat it. I put this up here, I thought might be interesting. This is sales data, market share data for NSLC, so just the NLC products that we have. And just to kind of highlight or orientate you, the lighter sort of green and yellow is the high potency product, right? If you just, on that range on the right-hand side, if you just move the decimal point, for example, that 300 plus is 30 plus THC, the 250 to 300 is 25 to 30% THC. And what we've seen, I don't have all the data that up to date, but those first few years, and even those first few years, we've seen that what's available to our youth and young adults at the NSLC is, in the last few years, moving towards that high potency product, right? And we're actually moving away, like it's harder for us as clinicians in a harm reduction model to try and find low potency or lower potency THC for our youth and young adults to use, right? So again, that's just the last 5 years, right? So different product today for our use. So just to summarize, when it comes down to psychosis risk, what are the things? It's not about just use or no use. We have to look at those patterns of use, right? So is it occasional use versus that daily or almost daily use? Occasional use probably is not going to have an effect for most people, right? But the regular use, daily or almost daily use, yes. That age of use, age of regular use, that's an important variable. The potency of product is a huge discussion point around this area today. But also just mention those are things that are, that we can control and that we can change and we can influence our youth and young adults to have that information around. But there are also some other things that increase risk that perhaps we don't have as good of control over. One is just being genetics. There could be genetics in the family, could be genetics just of that individual that may make them more predisposed to these negative outcomes for cannabis use, right? So when I have these conversations with youth and young adults, I say, yeah, these are things that we can control, that you can control. If you're ready, we can have these discussions. But there are other things we don't necessarily have control of, but we should be aware of it because it can influence your choice if you want to use or not, right? Okay, I put this in because this is actually a discussion. Oh, sorry, question. I didn't see.
Do you develop tolerance?
Tolerance? Yeah, that's actually a really good question because cannabis itself, there's a discussion about when we look at a cannabis use disorder, there can be tolerance. And you do see people kind of using more or using high potency to try and get the effect that they want, right? Sorry, it just made me think of something completely, almost not, a little bit different too, is that what our youth and young adults are going for, though, too, is that big bang for the buck, right? So they're going for high potency product, often because it's, you know, they can get more high compared to low potency product for the same price, if you want to look at it as kind of a marketing, right? And that's where the issue comes in too, right? Yes, sorry, yeah. Yeah, no, that's good. Yeah, very good. Oh, sorry, Nick, the organizer here, because I know we're actually going to have a question and answer period afterwards, but I take it some as well. But no, shatters and waxes, yeah, I usually have a picture that I put up on there too. So that is 80 to 90% THC, right? So a smoking product, what you can buy edible flowers these days is, you know, still high potency, 20 to 30% THC. The shatters and the waxes in vape pens and cartridges are around 80 to 90% THC, right? And those cartridges and vapes are very popular with our youth and young adults, right? It doesn't come in lower potency product at this point, right? But see, those are good questions. We can have the discussion after there too. So, yeah, go ahead.
You have comparison to alcohol and that, where alcohol decrease and stuff.
So sorry, the question I think is around if they're using cannabis, does their use of alcohol decrease?
Yeah, decrease since it was legalized.
Actually, I don't really have good data on that. Like, since legalization of cannabis, as youth and young adults, alcohol consumption decrease. I may leave that for Sherry to answer, because that's more her area as well, Sherry Renee. So hang on to that question, all right? I'm just going to end with this slide. This is one I brought in and spoke to our grade 12s, the grade 12 students I had to subject myself to last week. Sorry, Celine. But actually, they're a good group, very, very good organized, asked a lot of good questions and were engaged. And this is sort of the bottom line. You know, we're giving them the information. They have to have this information to make the right choices. But as well, we still talk about that bad trip. And this is their language as well, not my language. So we say, you know, you may have somebody or you yourself who may not have had a good experience using cannabis, right? We're supposed to be using it, and we want to use it because it should be a pleasurable experience. If it's not, and you're getting anxious, paranoid, a little bit sketched out, that just means you're probably at risk for more negative outcomes, and you should kind of step back and kind of evaluate how much you should be using, how you're using potency and things along those lines, right? And we see those benefits from our youth and young adults who have been able to step back with respect to their use. So that's one way of saying some of these things that we can't change, like genetics and other kind of background, and some of it we may not know. We can't necessarily test you for things like that. But if you have a bad experience, well, that's probably an indicator you shouldn't use. And I'll just end with this. Anybody's interested, and I can leave this link as well. This is a cannabisandpsychosis.ca website. It's a youth-developed, for youth information around cannabis and psychosis. We actually, and I've been privileged to be the medical advisor for this whole call it campaign or whatever, information series. But also very privileged to work with. There's a lot of good Indigenous youth leaders that have been a part of this as well that have been quite helpful. And I think I'll leave it at that. So Nick, are we taking questions now or up to you? Yeah, go ahead.
So can I, while we're getting the microphone working and we go into question and answer, we will have runners for mics. So if you put up your hand, the runner will go get the mic so everybody will hear your question. I will also ask everybody, please, to keep your chatter down to a minimum because sometimes it's hard to hear and it's hard to focus. So I'm going to ask people to, if you can respect each other and chatter down to a minimum, whisper, or go outside and have your conversation. So thank you for that.
Can you hear me?
You got it.
Yeah.
2 slides over. You
2 slides back.
bad trip you were saying, or
I'm
you
not
were
sure.
calling it.
There you go. That one?
Okay. I'm familiar with that term. Last 15, 20 minutes, a lot of you how you describe cannabis as advanced. So a bad trip, right? I know about those because I seen it with the youths when they have experiment with drugs,
Yep.
and a lot of them, some of them you call bad trip, but a lot of them we call as First Nation, gosset. Gosset means burnt, your brain, fried,
Okay.
and they were never the same. They're affected the rest of their lives.
Yeah. Yep.
And I see that mostly, and then some of the doctors coin it as allergic reaction,
No.
chemical allergy, or I hear that from some of them, right? Their brains are different. You said one person would be all right, the other person would be affected drastically. And this is what I was questioning my partner about, my friend Blair, about First Nation. All of your researches, I see it elsewhere, First Nation data, or do you have any numbers that's able to determine how drugs affects First Nation? Because I know our communities are plagued with addiction. And then when they introduced the legalizing marijuana, it took like grass fire. It
No pun on
took
grass
over
fire.
the
Yeah.
communities.
Yeah. Yeah.
And what I'm trying to say is what the youth, right? We're talking about youth when they experiment with drug early age, even smoking, vapors, alcohol. Their brains are not developed fully, right?
Yeah.
As
Yep.
they're not adults yet, and they're affected differently with the experiment.
Yeah.
And a lot of them have long-term, more advanced addictions at early age, and it's unfortunate.
Yeah, I fully agree with you on that, and I think that's why it's important for us, first of all, I mean, to know some of this research, and you're right, not a lot of this research has looked into all different cultures and communities. They have tried. More than happy to collaborate as well, because we'd love to actually work more with your community as well within this too.
To mention our brains, First Nation, they're different. Because I heard that because our process of oral history. Hello.
Yeah.
So, for thousands of years, we've been using oral history, and our brains are functioning different in terms. And this is mainly why we are prone to more addiction when we do it.
Yeah. Yes. So but this is all really underscores the reason to, and actually I think Chris, you will talk about this as well, to have these collaborations, to have these partnerships, so that we can understand it better. Like we can talk about these risk factors in the general sort of sense, and these are we've had 20, 30 years of this research in various types of populations, but again, where we moved from use versus no use to risk to now talking about use patterns and how that affects use, we also need to distill that down into other communities, groups, heritage as well, to see, okay, what other things should we be considered and have important with. So happy to be involved in some of that. That's actually research that I'd really be quite interested in as well. So good. Nick, are we doing more questions? We're good, as in I'm walking away. We're good for more questions. Oh, okay. Well, we have time for other, I think, questions. At the end.
Carrie, yeah, so I just wanted to say that we are going to open it up for discussions, but I just wanted to link it in saying that we have a lot of great work that is happening, and we've noticed that there's a gap, right? That we're talking about Canadians, we're talking about a large population of humans that don't necessarily include Mi'kmaq. This is why we've brought Chris out, to say that there's a Canadian initiative around substance matters, and there's an Indigenous platform where Indigenous people are coming together to talk about these things. which is where we're going to move into having CRISM come and now share about what they are, so then we can start thinking about what type of engagements, research opportunities exist that we as a nation, as a group of communities, can engage in through Dudgeygamic, through our health centers, in recognizing that research matters and research speaks for itself, and so how do we use it for the betterment of our communities, okay? So we are going to get to questions, but there's a good chance that some of those questions are going to be answered when we have our CRISM partners share some of their information. Sound like a plan?
Sounds good.
Beautiful. All right, so we'll save questions. We have 15, 20 minutes just at the end of this, which we'll open up for that piece, okay?
Thanks so much, Nick. We are truly honored to be here to introduce you to the Canadian Research Initiative in substance misuse. That's our old name, and we've recently changed to broaden it to Substance Matters. So I'm Sherry Stewart. I'm going to be tag teaming with Renee Mashing today. So we'll be going a little bit back and forth in our coverage of the content today. I'll have to figure out how this works. Should be the green.
Or, next slide, please.
It was working just fine for Phil, and then I get up here. Not sure what I've done. There we go. So I want to begin with a land acknowledgement. This is the formal Dalhousie land acknowledgement, but I just want to acknowledge that I'm very privileged myself to live and work in Mi'kma'ki, and that is also where our CRISM offices are located, in the ancestral and unceded territory of the Mi'kmaq people. And I also wanted to just acknowledge that photograph, that beautiful photograph there is actually in Unamaki, where we got together for the CRISM Indigenous Advisory Group meeting last year, which you'll be hearing about a little bit more later. So, what is CRISM? CRISM is a Canada-wide research network, and what we're doing is investigating substance use matters, initiatives around substance misuse interventions to help people who are suffering from substance use problems. And we really do research on the gamut from prevention, treatment, harm reduction, policy, public health interventions. We have 5 different nodes across Canada. It began with 4, so the Atlantic region was together with Quebec initially, and then they realized that we kind of needed our own node, so thankfully we've had our own node start about 3 years ago. Together, we're over 1,000 Indigenous and non-Indigenous researchers, service providers, policymakers, people who have lived and living experience of substance use themselves or among affected family members, affiliated stakeholders, and knowledge users. And we're located in both non-academic organizations, over 200, so for example, substance use harm reduction organizations, and private and public sector treatment centers for addictions, health institutions, health authorities, and then over 400 researchers, trainees, and academics from right across the country in more than 40 different academic institutions. And recently, we've come together through a national coordinating core center that have 4 different core platforms. So one is about knowledge mobilization, so taking the research findings and trying to apply them and make sure they're used in a useful way to improve things for people who are suffering from substance use issues. We also do training, so training people in doing research and getting research out into communities, capacity building. Also trials and project support for us to do larger scale kinds of studies that require large numbers of people to come to conclusions. And then we also do guideline development. So what does the research evidence tell us about how we should be practicing and support for those guidelines? Now I'm going to turn it over to Renee next.
Good morning. It's a real pleasure to be here. My name is Renee, and my bloodlines are from Six Nations of the Grand River in Southern Ontario. I've been living here in Mi'kma'ki for about 30 years, and it's a real privilege to have the opportunity to speak to you today. I'm here in place of Blossom Labilowa, who has been recruited, and I'm looking forward to my invitation down the road. I'm a student now, so I'll be hopeful for what's to come. So just very quickly, my background is in HIV research, and one of the things that's really been important about learning about research in that context for me, we talked about being researched to death. And just being sick and tired of researchers coming in, learning, taking information from us, and then going on and making careers. And what we learned over a number of years, because there was some funding that was dedicated to Indigenous work in HIV, is that we could research ourselves to life. And that really became an important context, and I think that's something that CRISM is really interested in as well, and that's why we have an Indigenous engagement platform, because there is potential when we're leading our research, when we're doing our research, when we're partnering with our allies to research ourselves to life, to learn what we need to know to be able to make a difference with our communities and our peoples. And that's really the goal of this group. So Dr. Bobby Henry is a Métis researcher. He's Red River Métis. He lives in Saskatchewan, and he has brought together a vision for this big national Indigenous engagement platform that's going to be influencing the work that the broader network that Sherry's been part of for many, many years is doing. And so really to work from sea to sea to sea with our peoples in a distinctions-based context, recognizing First Nation, Métis, Inuit approaches to research, knowledges, and how that all comes together. And to be able to make a difference, working both with the National Coordinating Corps as well as the nodes. And Heather Poirier is going to coordinate all that work. Her work plan's massive. So there's a big vision for how this work is going to come together, and it's about strengthening relationships, getting to know each other, spending that time to actually build connections, and again, to be community driven, to be in places like this where we can make note of your questions and go back and think about how do we work together, who asked that question, who do we want to follow up with, so that we can begin to develop that work. That we want to be really mindful about the context of substance use in Indigenous communities. It's unique, it's a different play, it's a different perspective, and we want to answer our questions and support our communities in ways that are meaningful. And that we really want to be grounded in relationality, so that the Indigenous Engagement Platform, the IEP, will be working with Indigenous peoples and communities. And what we learn in one territory, if there's a way to take it to another territory and scale it up to make it relevant, to make it useful somewhere else, we know things have to change, but sometimes there are really core principles and values that make sense here that might actually make sense over there as well. So we want to make sure that we can share that information. The way that the platform is engaged, there's again, these lovely Venn diagrams that show how we overlap. So there's a national coordinating center that's working for all of CRISM. There's our Indigenous engagement platform, and then the 5 different nodes across the country. And so everybody's working in their own ways and also trying to come together and overlap. And you can imagine this is a pretty massive undertaking, and it's new. The Indigenous engagement platform just began their work about 6 months ago. So there's lots of opportunity to shape things and influence things, and there's also a little bit of asking for some patience as things start to grow. And the way that they've designed, so within CRISM, within all these different circles, the Indigenous engagement platform is really seeking community leadership. So they have 4 advisory councils that advise the executive. There's an elders and knowledge keeper advisory board, a youth advisory board, an adult, and a senior. And we have representation from the Atlantic region on each of those advisory boards, as well as on the executive. And we're looking for some people to join us. So a little bit of building those relationships and seeing who's who and who's been where. Some of the work began that the IEP is funded by the Canadian Institutes of Health Research. That's the big funding body in Canada that supports health research. And so they began pulling the group together in the fall and then had an executive meeting and said, well, we want to have these advisory groups. And then they had another meeting in May that began to pull together those advisory groups. So that middle picture shows you 32 people out in Banff having a meeting to start to learn about how are we going to support this great big giant network of Substance Matters research. And then the last picture, you see some of our Atlantic Canadian representatives. So many of you will know Chris Brooks from New Brunswick. Nick was there. Blossom was there. Jennifer, who is sitting over in the corner, who works with CRISM Atlantic, was there. And so was Taylor McDonald. So these are some of our representatives who are influencing and making that work come to life. In Banff, there was a lot of conversation about how do we begin this work, really emphasizing the importance of being community-led. What are the questions that community members want to have answered? We don't want to do research for the sake of learning something. We want to do research because it's going to help community. It's going to help our peoples to be better, to contribute to well-being. We need some terms of reference. We need some ways of coming together. How are we going to agree to work together? So that was beginning to be developed as well. And certainly a recognition that this is big work. This is big work. It's complex. There's a lot of diversity. We share values. We share cultural connections, but we're also distinct. When we talk about First Nations, Inuit, and Métis, then we need to talk about Mi'kmaq and Wolastoqey. We need to talk about Cree and recognize again that even under this umbrella of First Nations, there's so much that we know is different and unique. So how do we take up what we can share, what we can learn, what can help us to create a foundation, and then make it meaningful and real for us in our communities and our contexts. And also a real commitment. This is an academic setting. We want to see students interested in substance use research. We want to bring students up and bring students in. So there's also some commitment to funding and mentorship to support student engagement. And then I'm back to you, Cher, to talk about our Atlantic work.
Thank you so much, Renee. So now we're going to talk a little bit about CRISM Atlantic, so the node that we have here. Now, this just shows you the structure that we've developed. So through consultations across the Atlantic region, we came up with 3 specific areas of priority for the research. So, consistent with our theme today, youth substance use was one of those 3 themes. Concurrent disorders, so mental health and addiction, but also addiction and comorbid physical health problems was another area that falls under concurrent disorders. And then something that's very important in the Atlantic region was rural access. So making sure that rural communities, people in more remote regions are able to access effective interventions. And so telehealth falls under that umbrella. So we have 3 working groups in those areas, but we also have 3 advisories that represent our priority populations that are cross-cutting and inform the work of the working groups throughout everything that we do. So we have 1 Indigenous Peoples Advisory, and we're going to talk a little bit more about what they've been up to today, sex and gender, and then also people with lived and living experience of substance use. And this just shows you the people. Those working groups and advisories are populated by people, and we're very lucky to have co-leads of each of the groups, so that really helps us if somebody has to move off and move to another position, that we can keep things going. So this co-lead has really worked, and as you can see, there's some spaces. For example, Blossom's space is now open. So we are looking for new members and people that would like to get engaged. Hint, hint. And we're really happy Miranda's here. Yes. This just shows you the growth in CRISM Atlantic over the years. It's been really exciting for me, who's been involved from the beginning, to see the growth that's happened. So when we launched in 2021, we had 170 members. And we've pretty much doubled since that time. And as you can see, we've had growth in all the different areas, from trainees to researchers to service providers to people with lived and living experience and so on. And our goals really are around networking and bringing people together to do research together that's meaningful for the service providers, the communities involved, the people who are living with substance use issues. And just to note that almost 20% of CRISM Atlantic's membership is Indigenous members. And so really what we're trying to do is work together to identify or develop the most appropriate clinical and community-based prevention or treatment or policy initiatives in the area of substance use, to provide evidence to enhance prevention and treatment services regarding substance use to decision makers and service providers, and to support improvements in the quality of care and the quality of life for Indigenous and non-Indigenous people in Canada who are living with substance use issues. And these are our research objectives. So we're looking at research that identifies risks, protective factors, consequences of substance use, that we're working together to co-develop and evaluate novel, meaningful, and importantly, accessible interventions that people can make use of. And we're broadly looking at psychosocial interventions, pharmacotherapy, policy changes, and really establish bi-directional relationships between research and practice. So we really try to be bottom up, that the questions come from the community and the needs of people living with substance use issues, and they drive the research agenda, but that the research comes back and informs the practice. And we also do support getting new research started. So we have a research development program, and there's an annual funding call to all members of CRISM, and it helps them develop their research projects. And we have two types, promising projects and emerging projects with different levels of funding. I think we funded over $170,000 worth of grants now from the research development program. And and we've had real return on investment so that people have used those to get pilot data and then apply for bigger projects, right? So it really helps people get started. We also have demonstration projects. Oh, and here are some of the examples of some of the projects that have been funded. And one in particular I'll just pull out because we don't have time to talk about all of them. But Charity Fleming, an Indigenous social worker, has paired up with people at the Dalhousie Center for Psychological Health to adapt a cognitive behavioral therapy program for youth substance use issues. And so that's quite an exciting new project that's been funded through the research development program. There are just a few others for people to take a look at and see what all we're funding here for those projects. Demonstration projects are slightly larger, still, getting people going on research, but on bigger projects that are more potentially cross-site. So each of the working groups has their own demonstration projects going. Here are a couple of examples of ones that are underway or have finished up. So there's one on youth vaping. So Sanja Stanjevec was the lead of this one, and she was really looking at vaping and how it impairs lung function in quite young people, right, in adolescence. And so it was really around determining the feasibility and design of a future larger scale cross-node population health study. And then OppaVenture, I'm involved with OppaVenture, so this one is looking at bringing more psychosocial skills-based programs to opiate agonist therapy clinics, which largely rely on the OAT medications, but don't often offer much in terms of psychosocial programming. And I'm going to turn it over to Renee again.
Okay.
We're really tag team.
We're coming to the home stretch here. So you're a member of CRISM. What does that mean? What's going to happen? What's the purpose? So we have a couple of different ways that we'd like to engage. And so I'm standing here in a position that Blossom held, and before Blossom and before me, we had Nicole with us as well. And Nicole helped to coordinate Researchers Healing, which was an event in Moncton in 2023. It was fantastic. More than 100 people came in person and online, and it was really that opportunity to begin to talk about what could Indigenous engagement, Indigenous research about substance matters look like for Atlantic Canada. And so part of the context was creating a safe space. There's a chill zone, a space to hang out and have a little bit more context, or a little bit more space to to chill out, really. And so it was a combination of having, I think we called it a tea party. I wasn't able to attend the event, but this was the first engagement to really talk to Indigenous communities in the region, to Mi'kmaq communities, to Wolastoqey communities. We haven't done as much work in Labrador yet. And to hear about what does research mean to us? What does, and this is what the word cloud is showing you. The perspective that came out from community, but what are we interested in, what do we need? And you'll see the really big words around empowerment and healing, education, the OCAP principles in research about ownership and control, access and possession of our research data, looking after data sovereignty, looking after research about us, for us, with us, and by us. We had a co-learning Maui last summer, had an opportunity with Miranda and I as co-chairs and with our advisory committee members from across the region to meet with and have guests join us. We had a Maori researcher join us, Elder Albert joined us, Kathy Martin joined us, and helped us to think about, again, as an advisory group, how are we contributing to the work that's happening here in CRISM? And we're always welcoming more advisors if you're excited and interested. Within CRISM, and this is part of our national work and some of the responsibility Atlantic Node to offer training, we had a sex and gender-based analysis, a series of workshops and webinars. And so this is talking about, when we're doing our research, we want to think about how we understand differences for different people. And in the context of sex and gender, do women, do men, people who identify as women and men, people who identify as two-spirit, people who identify in other ways, how do we make sure that that's part of our research? We pay attention to that and include that. So these webinars were resources to help think about that and start to present it. And Elder in Residence Sheila Nyman, who's from BC, is actually co-leading the Institute for Gender and Health at CIHR, which is a really big deal. She's got a very important position there, and she helped us to plan these sessions as well, and to open those and to close those, and think about how we were talking about sex and gender in our research. And CRISM Atlantic hosts a symposium. So again, as a member, you're invited to come to the symposium. It's a gathering across the region. And our last one in November 2024, we had more than 100 people join us. We had speakers, invited guests, we had presentations, we had working groups, our working session kind of, standing at the front of the room and asking questions like Phil did to really get people engaged and think about how we talk about stigma and how we talk about stigma in a way that is respectful and not harmful. We had poster sessions, we had speed dating, introducing students and researchers and newcomers to research, and we had that chill space again, that place to just kind of process a little bit and take a step away. And you'll see some pictures of some great presentations that were made. And really the heart of it all is bringing people together. We want to get to know each other, we want to know what's important, we want to share. As researchers, it's really exciting to think that you've learned something that other people might care about. And to share that, give it back, hear about it, find out if you're on the right track or you're not on the right track and it's time to change direction before you go too far the wrong way. So this symposium is really helpful for that. And this is how you can find us. And really, through the website, through our email, please reach out. And we want to have that opportunity to develop research and projects that are meaningful to you. Thanks.
All right, thank you so much for that. We have some floating mics around. So if anybody has any questions, comments, thoughts, we'll start off over here with Carrie. And just patiently wait for that mic to show up, please.
Hi. I had two kind of questions. One about the bad trip, and I think alcohol comes into that play. When people have a bad trip on drugs, they use alcohol to cut it off and make it a better trip. But I have a real concern about vapes. I walk around, I walk on roads, and it's like you see cigarette butts all over the place one time. Now you see vapes laying on the road, sidewalks, walking through university, you see them on the ground. And I wonder about kids and seeing these things and seeing them in adults using them. I don't know if there's any research on, the potential of kids finding one that's still alive or still got stuff in it, using it. And I don't know what the safety procedures on those vapes are, if there's any decommission of them, you know, if they're not working anymore. I don't know if there's any research on that stuff, and it's a real potential hazard for our young people.
Is this working now? Yeah. Hi, everyone. I'm Celine Etches. I'm a child and adolescent psychiatrist at the IWK, so I was asked to come for the question period in case you have any questions about the actual kiddos that we are seeing. I run the provincial clinic for substance use, so I'm usually seeing a lot of that kind of higher level of use, so IV use or homeless, they're linked homeless or things like that. So I'm seeing up to age 19 through that clinic all across the province. So what I can say about vaping is that nicotine is probably the only substance that's actually increasing in youth. Everything else is kind of going down, although I kind of would question about the cannabis and the high potency, and we can talk about that. But nicotine is actually going up and vaping is going up across North America, and I think it's just very, very easy to get. Brand new. I don't think they have to find them on this side of the road, although of course they could, but definitely we're seeing, and what I see is definitely in the junior highs particularly, a lot of youth vaping, which then we see progression to the cannabis vaping, which I would say since about 2023, we've seen dramatic increases in that high potency. Someone said shatter and dabs and wax. We're seeing dramatic increases. And it's interesting because before that, the kids would say, oh, you know, I was like, do you do shatter? We always ask about the THC potency, right? And they would say, well, no, it's so expensive. Maybe once every couple of months, it's just too expensive and it's too hard to get. I can't afford that. Now, since about the past 2 years, that's pretty much everyone is coming in using the high potency, you know, 90. I know Phil said 90. I have kids using 98% THC vapes, and like the effect on their mental health is really dramatic. These are not happy kids. I can say that in many, many ways, not just the psychosis. So I would say that vaping progression is very. I will say, though, as the kids get older, around 18, 19, they tell me, like, oh, vaping, you look like a loser. I don't want to do that. That's where, you know, I want to give it up. But it's hard, right? Because it's also the potency of the nicotine in the vapes is up to 50 nic, right? So very, very high. So, and they're smoking so much. So one disposable vape, which some kids go through in about a day, is 100 cigarettes. And that's at 20 nic. So 50 nic is even more. And they're just, you know, becomes your life. Yes. Yeah. Well, I can say at the IWK, we do see a lot of accidental poisonings. We're seeing more accidental cannabis poisonings for sure, but there have been some nicotine intoxication that we have seen coming in with toddlers getting into the nicotine vapes as well.
So on the product itself, is there any safety precautions or anything discarded?
So the question is, are there any safety precautions on discarded vape? No, I don't think so. On the nicotine vapes, no, I think it's relatively. Cannabis packaging is very, when it was legalized to the NSLC, it's supposed to be very bland. So it's supposed to be white, and it has a, I think, red cannabis leaf with a no sign, you know, that don't do it, and warning labels and things like that. Not to make it attractive. Don't flavor things, right? Because obviously nicotine doesn't taste good. It burns in the vape, but if you flavor it with bubble gum or cotton candy, then it tastes good. So, you know, then you use it more. You don't have that adverse effect. So kids kids lean towards the flavors. Let's say that, right?
One of the studies that CRISM is funding is youth and vaping, and I'll just let you know that the preliminary results from that study show it's for youth, and it shows a significant impact on youth's lungs and airways. So that information really has to get out there to educate folks. So they are really seeing an impact there for youth. So just wanted to let you know that. Thanks.
I just want to, with the vape stuff, do you guys know if this ain't my question, but it's just like, what's going on? But do you guys know if there's anything, because they're so discreet, like, they're discreet, they don't stink, like, who do we talk to try to make that noticeable that you know someone's smoking cannabis, especially within schools? Another counselor from our community mentioned that they get away with it in the bathrooms in schools, and I know that's across the country. And so, who do we talk to make them not as discreet? Yeah, but
Yeah,
my original question was, with your guys' studies, is there any studies that show that this is like a gateway to harder drugs, especially where people gain a tolerance, and if they're using cannabis to get that high, especially if they're trying to bury feelings, like once that high isn't enough, they're going to try to find something more. And is there any studies within that it does lead to more dangerous drugs? Like, so yeah, 2 questions.
So I think, 2 questions. So I'm going to start with the first question. We are doing a project in Nova Scotian schools, and it's called the Canadian. We're one arm of multiple sites. So Nova Scotia is one arm of multiple sites, and it's called the Canadian Underage Substance Prevention Program. It's very interesting because quite consistently from the schools, they talk about vaping being the thing they really want to tackle. And it's because it's so accessible for the kids to be able to access it, right? And people not know that they're doing it. And we do know accessibility, makes more substance problems. And like compared to tobacco, where you could, catch somebody in the washroom because of the smell, you don't have that as much with vapes. Right, exactly. Yeah, so the schools are very aware, and this is one of the things we're trying to do with CUSP, is see whether our program actually reduces vaping use as well, because we don't have good prevention right now for vaping. And in terms of the gateway, I don't know if anybody else wants to tackle that.
I would just agree too with the accessibility of it and the ease of it. I have a couple kids who just keep it in their sweatshirt just right here and then just right in class. So they're not even heading to the bathroom. And agree too as well with the fact that it's high potency cannabis vapes, not nicotine flavored high potency cannabis vapes, right? So fun, accessible, easy. In terms of the gateway, that's hard to say. It's not so much a progression. You start with nicotine, then you go to cannabis, then you go to Xanax, then you go to crack, then you go to IV. It's not so much that linear, but the risk factors of developing that progression are all very much the same. And so when you've got kids who've had trauma or don't like school or have learning disabilities or family fighting, or they have that genetic risk of substance use, and then they start using something that makes them feel good and makes that all go away, and then you're right, that stops working, or you start having negative effects. I had a kid go psychotic off the high-potency vapes and then started using other substances to cope with those symptoms. That's where we see that real progression, and then that sense of just feeling really trapped and stuck, and how can I get out of this? And missing out on a lot, right? Like I just saw a kid last week who, he's now 18, and for the past 2 years, he's been using high-potency cannabis vapes all the time, and then everyone's graduating, and he says, look, like, my friends are going off, and they're doing stuff that I thought I'd be doing, and I missed it all, and what am I going to do now? And then because you're 18, you think, well, that's it for me. I'm done. There's no life for me now, right? And so very depressed and very suicidal. So that's where, and what fixes that better than anything? What takes those emotions away super fast? More drugs, right? Yeah.
I got a question. I asked earlier if there was any research. I'm right here. If there was any research on, because a lot of people, they say, oh, I'd rather be doing, rather smoke marijuana than do alcohol. And a lot of the lesser of all, both evils would be doing cannabis. People are still sound mind, you know, for the most part. But was there any decrease in alcohol consumption since the legalization of marijuana?
My understanding is there has been decreases, but it started before cannabis became legal. So I wouldn't attribute the change to like more accessible cannabis means less alcohol use. There were trends that were already in place before cannabis became legalized. Yeah, that's probably all I have to say.
I can say clinically, and again, that's my focus, right? Seeing the kids, is that I would say because cannabis is so easy to get, kids are going to go with what's easy and cheaper, and it's harder to get alcohol now than it is to get cannabis and the nicotine. So, but overall, alcohol is still so easy to get that there's still a lot of alcohol use, usually in the binge drinking. So cannabis is more moving to that high potency vapes every day, whereas the alcohol is still, we're seeing that adolescent pattern of just getting really, really wasted and, you know, bad things happening. Yeah.
I just want to go back to the vapes if I could. I sit on the education working group for all our MK schools across Mi'kma'ki, and we've talked about vapes. It comes up every meeting. There's actually a gentleman in Unama'ki who there's vape detectors that you can get for the schools. I do believe one of our schools got them. I'm not sure. I don't remember which school, but they were supposed to be installed to see how successful they were. So I do have the gentleman's contact information and his name if anyone wanted that information. And it's through, most of our schools are Apple certified, so it's through Apple Education as well.
I was wondering, is there any studies on cancer for these young children? Is it an increase with vaping, and how quick will they get cancer, or am I barking up the wrong tree?
No, I mean, first of all, that's an excellent question. I think where we are now with the research is too early to say. You know, there takes that time for some of those illnesses to develop, like cancer. It takes time. So, you know, we're dealing with the last 5 years, last 3 years with, you know, youth and young adults using really high potency products daily or almost daily basis. Unfortunately, it's going to be a number of years before we see some of those types of outcomes, right? But that is something that needs to be followed, and I think we have processes in place to follow that. But I don't have a good answer, but still concerned as well. I mean, you think anything that you put into your lungs increases that risk, for example, of lung cancer, but there are other oral lip cancers as well that have to consider as well. So there's other health effects. I know we're talking about mental health, but there are other physical health effects. We've been doing some work looking at emergency room presentations, cannabis-related emergency room presentations. And we are seeing some, especially in youth population, and we're seeing some increases that we've never seen before, including cardiovascular, like heart-related issues that are coming into emergency departments. So that's one of those early signs. We're seeing increases in emergency room cannabis-related emergency visits. You know, that's not a good thing. So we're really following that data, and we have some papers that will coming out quite soon with respect to that. Have a great question.
Awesome, thank you. So just to jump in for a quick second here, we're going to take 3 more questions. I'm going to put my former co-chair hat on and manage and take over this agenda for a little bit. So we're going to take 3 more questions, and then we're going to break for lunch. I just want to let everybody know that the panel will be staying, and you're going to have lunch with us. Yes. So if you have any questions, they're allowing you to come and talk to them. So let's jump into those 3 questions. So we have Charlotte, I believe.
Just out of curiosity, the youth, are they telling you where they're getting the vapes? How they're getting the vapes?
Yeah. Honestly, primarily on reserve. So there's two main sources. On reserve is the primary, and then sometimes mailed from online sources, but primarily on reserve.
Who had
Hello?
the second question?
Right here.
I see your hand, right? Chief Tamara.
So I saw one of the stats there earlier said that Nova Scotia had the highest use, and I know Nova Scotia also has the highest cancer rates. Did you guys distinguish your studies, or are you going to distinguish it based on recreational use, medicinal use, or just is it all lumped in like general use?
So Nova Scotia is the highest rates in the country for cannabis, like woohoo! But cancer and cannabis is not a huge link, to be honest. There's like the same with nicotine for sure, and that's more from cigarettes actually. So we don't, and like we said, we don't know the vaping, but with cancer, it's more chronic obstructive pulmonary disease, the COPD exacerbations, the bronchitis exacerbations for the cannabis. There's no direct link between cannabis use and cancer that they've found yet. So. Oh, for cannabis for medicinal purposes? Yeah, for like nausea and vomiting associated with chemotherapy and things like that. So I think some people do use that. I think the studies have shown that that's kind of a fourth line treatment, like the medications seem to be better at managing that. But that maybe the CBD formulations, particularly, I know Phil talked about CBD versus THC, there might be some more helpful, especially for that nausea and vomiting, some maybe pain. CBD really attacks those receptors that are more in the body. And so, but it's really hard to get CBD, like Phil said, because sometimes I say to because parents are like, well, I don't want them getting it, I'll just buy them the cannabis as we try to get off this. And I say, well, try to get the CBD. And where? It's very, very hard because the market, like Phil showed, is for that 90% stuff. And yeah.
I believe we have.
Okay,
Tommy
I got
J.
two questions since I waited. So the very first one was looking at why don't we start testing with the nicotine patches? Because I see those all the time too with some of them sometime. When they go on trips and stuff, they're using those as well. They even told me already if they go against with taking the vapes, they're going to use the nicotine patches in the schools. So they're already trying to think ahead what we're going to do for the next one. You know what I mean? Like it's a constant battle. That's what we're up against.
Yeah, so like when you get dependent on something, you're going to have withdrawal, right? And that's what we see with the drugs all the time. It's they're managing their withdrawal often by using the substance again. So in that process, we have some substances where we have some good withdrawal management strategies. So nicotine patches, nicotine gums, there's some medications that can help with nicotine. Cannabis, we have a couple things. There's a herbal medication that can help with cannabis addiction for adolescents. We could use synthetic cannabis sometimes. Nabilone is the medicine to manage the withdrawal. It's really hard to manage withdrawal. It's really hard to do it without help. And then we know that's a relapse risk factor, right, if we don't manage withdrawal. So, but you're saying maybe that'll lead to more problems like abusing
The other thing that I'm
patches.
seeing that I seen last year was the mushroom bars with the vapes now.
Yeah, the mushrooms.
The mushroom vapes.
Yeah.
That's
Yeah.
everybody's being quiet about, but you see it. You know what I mean? Like they're all out there. You know what I mean? So they're starting to hit those now and stuff too. So it's very hard. Like when you see those even happening.
Yeah, absolutely. So you're seeing it all, and you're worried about the effects on the kids and the community.
Wrap it up.
Yes, because sometimes these youth are like, my son could say, you know what? I'm not coming home tonight. Why? Because I'm babysitting this person that already took something. And I don't get mad, but I know at least I'm not worried no more. But he's staying there until tomorrow or whatever, and then I'll pick them up. Like they look out for each other, but they take too much. Right?
Thank you, Tommy J. Now we have time for one more question. Just one more. And I see Buster's hand up there.
Yeah, well, I got 3 questions. No, I just got the one concern. You've talked about medicinal cannabis, and it was approved in 2001. Has there been what are the studies that have taken place to make cannabis medicinal? I mean, I don't understand. I mean, is it mental or is it physical, or I mean, it creates so much harm, and yet they say it's medicinal. How do they do that? That's my question. How did they come up with cannabis and say it's medicinal, and then have this battle going on 20 years later? No, now it's recreational.
Yeah. No, I appreciate that. That's actually a really good comment. You know, how can we call it medicinal, but also have all these discussions around these negative outcomes of it as well. And actually, you know, as a country, we kind of did ourselves a disservice, because when we legalized for medicinal, what we saw up until the time of legalized recreational use was all this information without any basis or research saying cannabis can solve everything, you know, can cure everything, can help with everything. I was getting faxes in my office, you know, with actual wording about curing certain things when we know that it doesn't, right? And actually, there's only a few indications where cannabis actually could be helpful. And Celine mentioned a couple of them, you know, nausea and vomiting with respect to chemotherapy, some of the pain disorders as well, you know, one sort of very bad type of juvenile epilepsy as well. But that's all. Everything else is not, there is no actual findings. We've actually looked at some of that literature and published on, you know, what is, you know, where are the studies that show some of these medicinal uses? And we don't have a lot of good supports, right? But I always still take the approach that, you know, cannabis is there. There's about 100 active chemicals in the cannabis plant. There still may be elements, for example, the CBD, that could be useful. But we need to still do the research on that as well, right? So from a medicinal, you know, that's a very limited range. But again, those are usually for adults that have passed this, you know, youth and young adult phase that we're more concerned with. But we still got a bit of work on that. But I still think we, you know, from that time we legalized medicinal to recreational, there's a lot of misinformation that went out there, and we're just trying to rein some of that in at this point in time.
All right, thank you very much. And before we break for lunch, because I'm getting eye signals, I'm getting this from some of my godchildren. And just want to let everybody know that the lunch is ready, but we're going to ask that we have diabetics in the room that should eat first. We ask that you eat first, and we have our elders in the room. So please go out and get your meal and come back in. And if you see them come in, just, you know, stage yourself before you head out. Another thing, too, I want to remind everybody that we have notes and Post-its on the table. If you have thoughts and ideas, you can place them on the wall. And before our panel leaves, I just want to thank you for being very informative, and also thank Nick for facilitating. And I see Deanne. Yes, please come back at 1:15. No later, 1:15. I believe I'm on the agenda, and I'll be starting at 1:15. Have a good lunch break, everybody. Thank you. Yes, give a round of And I see the doors closing. And I see Nick. Maybe shut the 2 back doors. He's got them. 30 seconds. Yeah. There's nobody else on the wall. Okay. Okay. All right, welcome back, everybody. I hope everybody enjoyed your lunch. And if you have blue teeth, blame the staff. And that's a good thing. So welcome back. Bringing us right back into discussion this afternoon is Nick with the second panel. This one focused on culturally grounded approaches to mental health and addictions. Okay. Okay. Let me be blunt. Y'all too loud. Y'all too loud. The chitter chatter that's going around the room, it really affects the speaker, just to let everybody know. It's hard to hear. All right, thank you. Let me start again. So welcome back. I hope everyone had a great lunch. Bringing us right back into discussion this afternoon is Nick with a second panel. This one focused on culturally grounded approaches to mental health and addictions. Nick will be joined by representatives from CMM, UNSM, and NADICA. So let's welcome back Nick to the stage.
All right, welcome back. We're gonna catch you all now before those carbs kick in, and we have to do some res stretching to get our heart pumping. But let's move into our panel for this afternoon. And as Annie acknowledged, is that we're gonna spend some time talking about some culturally grounded, trauma-informed practice work that is happening in community right now. And so I think it's important to hold space to hear from our Mi'kmaq organizations who are on the ground at the front lines doing some amazing work when it comes to mental health, well-being, and healing. And so we would like to invite Michelle Francis from representing Confederacy of Manland Mi'kmaq and our mental wellness team there. We're also going to invite Kara Paul and Buddy to represent UNSM and their mental wellness team, and also inviting Wagadeska and Donna up to talk and share about the amazing work that's happening at NADICA. So if you humans don't mind coming up and joining us here. Run, run, run as fast as you can. Just kidding. That works. All right, you're all set.
Hi, everybody. Walalio for the invitation to be part of this discussion today. My name is Michelle Francis, and I'm from Sabaganakadi, and I live in Pictou Land and First Nation. I'm also the mental wellness manager with the Confederacy of Mainland Mi'kmaq. I've been with the CMM mental wellness team for about 4 years now, and I'm really honored to share the work our team has been doing to support mental wellness and healing in our communities. So from past to present, our mental wellness team officially formed in 2017. The team started small, but with a clear vision that mental wellness should be rooted in culture, community, and passion. Today, we've grown into a team of 9, which includes cultural youth support workers, mental wellness case managers, Mi'kmaq support workers, and a resolution health support worker. Our team is a beautiful reflection of collaboration. We're deeply guided by the principle of Etowoptimum, or two-eyed seeing, by bringing together Mi'kmaq knowledge systems and Western mental health practice, holding both with respect. So for our approach to healing, we recognize that healing isn't one size fits all. Our belief is that everyone deserves the autonomy to choose the methods of support that feel right for them, whether that be one-on-one support, cultural connection, or learning new wellness skills. We meet people where they're at, spiritually, emotionally, and culturally. This means we offer programs and services that bring balance, choice, and culturally safe care. To strengthen cultural identity and connection, our cultural support team offers workshops like hide work and leather work to make drums and rattles. We've had regalia one-on-ones for youth and group moss bag sewing workshops. We also enjoy bringing the game of Waltus to community members of all ages. These spaces do more than just teach a skill. They offer moments of intergenerational healing, cultural pride, and reconnection. We also share medicines with the community and create opportunities to explore and use spiritual tools that support and strengthen cultural connection. In addition to cultural programming, our mental wellness team provides workshops and support sessions on topics like anxiety management, emotional regulation, self-care, goal planning, and coping strategies. These are practical tools for everyday life that are grounded in wellness but flexible enough to reflect the real experiences of our people. These mental wellness supports aim to build individual and community capacity, fostering resilience and long-term healing. We also build community capacity by offering mental health first aid and nonviolent crisis intervention training. We host a minimum of 3 annually, and these trainings help community members, caregivers, educators, and frontline staff recognize the early signs of distress, respond in a calm, non-judgmental, and trauma-informed way. These tools help create community support that doesn't just come from professionals, it can come from each other in community. So to look at some of the past year, the data from the past 2024-2025 year, the CMM Mental Wellness Team facilitated 76 workshops and supportive programmings, reaching 527 participants across our 8-member communities. These programs included cultural teachings, youth mentorship, wellness check-ins, and community-based initiatives that respond to the unique mental, emotional, and spiritual needs of our communities. In addition, we also hosted 2 healing retreats specifically for women and Two-Spirit individuals impacted by family violence. These retreats offered time away, time for reflection, and time to reconnect to culture, ceremony, and community in themselves. The feedback we received highlighted the importance of continued access to wellness programming. And if we're looking at the future, we're trying to build this momentum by listening to community voices closely. Next, we are working on men's and Two-Spirit programming. We recently held a men's and Two-Spirit gathering, and we're committed to expanding these spaces. These voices need safe, supportive environments too, and we are dedicated to filling that gap. Family Violence Toolkit. This toolkit was developed as a supplemental resource to support participants of our family violence healing retreats. It is a culturally grounded tool specifically for Mi'kmaq individuals impacted by family violence that offers information on types of violence, safety planning, local Mi'kmaq resources, etc. Our goal is to host engagement sessions in community to introduce the toolkit with a focus on safety planning and cultural healing. We are also working to ensure the toolkit is widely accessible and distributed. We are also working on developing a culturally grounded grief support program. We're working with Indigenous therapists, elders, and knowledge holders. Our goal is to create something doable, effective, and rooted in Mi'kmaq ways of being. We aim to create something that reflects how our people experience loss and healing. We are also working toward an Indigenous suicide intervention training program. We recognize that existing models don't always reflect our realities or our experiences, and our aim is to create a response that speaks to the specific needs, history, and resilience of our Mi'kmaq communities. We are actively exploring and developing strategies to better support the mental wellness of our elders. Their well-being is a vital part of our community's health, and we recognize the importance of being intentional and culturally respectful in how we provide care and resources tailored to their unique needs. Our goal is to create programs that support and honor their wisdom, promote their healing, and ensure they feel valued and connected. And right now, one of our biggest long-term goals is to secure sustainable funding for a dedicated crisis response team. Right now, when crisis happens in our community, we respond by sending emotional and cultural support. But we also know that this isn't sustainable and it can lead to staff burnout. Our communities deserve a response team that's resourced, trauma-informed, and ready to act with care and consistency. So all of this work is grounded in our communities, and we're here to walk beside people in their healing journeys, through ceremony, through crisis, and through everyday life. We like to offer the notion that wellness is not out of reach. It lives in our culture, in our teachings, and in the strength of our people. Bulalio for allowing me to share today.
day. My name is Buddy Young. I work with the Union of Nova Scotia Mental Wellness Team as a team lead and as cultural support. Here's our team members. We recently just added a couple of team members, Nadia Denny and Keisha Bernard. Then we also have Chelsea Google and Megan Bowers and Deborah Guinish. So Deborah Guinish was doing Indian Day School files, but she now transitioned into child and youth compensation file. So she's a coordinator for that now. And Megan Bowers does the behavioral support, and the rest of the team does case management. There are some of the programs and services that we offer. We know, just like a typical mental wellness team. I forgot to put my timer on because macht tunay na sometimes. So, programs and services is typical what you would expect from a mental wellness team. You know, we cover from provide any services, navigational supports. You know, sometimes our clients want to reach out to clinicians or therapists or any kind of services, addictions programs. So we help them reach out to these facilities, help them navigate sometimes the hospital, as well as we also do a lot of visits through to the jails, prisons, and courts. I'm part of the wellness. I'm part of the wellness court in Wahamakuk, but we also help our community members in different types of courts elsewhere as well, including Sydney and Skazoni. We do a lot of other workshops and trainings, such as adverse childhood experiences or trauma-informed work. We do a lot of trauma-informed work. We support Jordan's Principle. You know, they need, sometimes they do a lot of work around support around letters and stuff like that, support letters and navigation services. Some of the highlights, we did a lot of things. We volunteer usually in the summer games, Indian Day School, Two-Spirit Camp we held, cultural supports and ceremonies, land-based healing, mental wellness team training for trauma. These are the case management stuff that some of the girls do, writing letters such as to help clients secure essential services, including respite care, groceries, transportation, even something as simple as just trying to advocate for them to find places to stay, like apartments and stuff like that. Which also, I forgot to mention, we also visit a lot of places such as the Jane Paul Center and the shelters in Sydney there. And we also help some clients that are living on the streets. So we got a small team, but we're spread pretty thin, but we try to cover as much ground as possible. Counseling, we offer mostly soft counseling now, but we used to have a psychotherapist as part of our team. So right now we don't have a therapist, but we have to outsource. So we try to connect people with wherever our clients are comfortable with. You know, sometimes they want they want someone from our community to help them with counseling, and then there's a lot of clients that also want somebody that's outside our communities, you know, or non-Indigenous. So just for privacy sometimes. So we try to help clients wherever they feel comfortable with. You know, we try to help them with those kind of services. This is our child and behavioral support. She just goes to schools and help a lot of children, especially like autistic. We try to teach the children behavioral strategies, as well as the teachers and parents. Sometimes she also helps them, teaching them some strategies with our children and youth. Indian Day School Sports, I mentioned that. Cultural support, traditional healing services. This part here, you know, it's we do a lot of support around cultural supports around traditional healing services, and what that means is, as Nick mentioned earlier this morning, you know, a lot of services studies are coming out more and more that we're finding that there's a direct link to helping our people, and they're getting healing through on-the-land healing, basically. So, and it doesn't necessarily mean just ceremonies. It means ceremonies. It means connecting with traditional healers, traditional knowledge keepers. It means hunting, fishing, doing things on the land, arts and crafts, anything from beading. So anything under the realm of culture, it really, really, really is helping. And I'll get into that a little bit more. But we do a lot of other services, such as we do a lot of sacred fires for like wakes and stuff like that. And I offer it to all our communities in Unama'ki, but usually it has to be requested. I don't try to put it upon people, but I let people to request it. And when it's requested, we do our best to support the families on what they want. So sacred fires, they've been very, very popular lately because it's, especially with the Indian Day School and the residential school, a lot of our people are, seeking an alternative to healing, especially when it comes to grieving, So it's really nice to have choices. And some people prefer both, some people prefer one or the other. But it's really nice to have a choice for people, and it's very comforting, because our people, a long time ago, we didn't have therapists, we didn't have all these fancy stuff to help us with all these problems. What we had was ourselves, our people. And our people did a lot of things like talking around the campfires. 500 years ago now, they talked around campfires, they did cultural activities, they made stuff. And as you're sitting around doing these things, you'll be talking, and you'll be talking about your problems, and people will counsel you or help you or make laughter, they'll help you forget about it. So a lot of our people already understood this, and a lot of these activities are proven to be effective. I'll go back to this. This is Three Circles approach to crisis, but I just want to continue on with the culture. I got this from the Thunderbird Foundation medicine wheel. And the medicine wheel, it's pretty useful when you try to take care of yourself, you're physically, spiritually, emotionally, and mentally. And that's kind of common sense, But Thunderbird asked, okay, why is on-the-land healing working right across the country? They asked, like there's Bilwi Ilnu, there's a lot of different Ilnu people across Canada. They have different traditions, they have different protocols, they got different kind of ceremonies. So, but yet they were finding that on-the-land healing was working right across Canada. And when I went to Manitoba for National Mental Wellness, it was like a summit or a conference. And these are the things that kept repeating itself. So Thunderbird asked, okay, why is it working then? You got to take care of yourself. You got to take care of your physical body, spiritually, emotionally, and mentally. But why? Why is it working? So they realized when they start asking elders right across the country, even though there's the difference in protocols and culture and ceremonies and languages, they all came to a conclusion, and the conclusion was that when you're taking care of your physical self, that's a way of being, and a way of doing things as a wholeness. And you get a sense of purpose. It creates a sense of purpose. So when you look at our people, we come from layers and layers and layers of trauma, multiple layers. I teach adverse childhood experiences, and Ilnu people are born with a minimum of 2 or 3 layers of this trauma. Because you're born into residential school, you're born into epigenetics or blood memory, 500 years of trauma, and you're born on a reservation, you got and racism and all these things. And then as you're growing up, you start adding more traumas to your life. So as you're growing up, you'll experience either depression or suicide or alcoholism or drug abuse within your household. And your household, as an Ilnu person, doesn't necessarily mean just your physical house. Your household usually expands to your neighborhood too, you know, or sometimes your entire community. That's your household because you're growing up in other people's houses, you know, like your aunts and uncles and everybody's around you. So anything that's happening in your household or your community is affecting you because if there's thoughts of suicide or depression or alcoholism, you get a point in this scale out of 10. So each time you get a point, your trauma levels go up. And then if you are unlucky enough to experience direct trauma, such as sexual abuse, physical abuse, neglect, then you're getting more points again. So by the time you're a young adult, teenager or a young adult, you're probably going to be 7 to 10 ACEs. You're going to be maxed out by the time you're a young adult in terms of traumas. So now with all these traumas, just like we talked about marijuana and stuff, somebody asked if it's a gateway drug. And technically it is when you add up all these traumas. The cannabis itself won't be a gateway, but because you have all these layers and layers and layers of trauma, and nobody's immune to it. Some people think, oh, I was raised right, I was brought up right. But no, it's all around you. So the entire mentality of your entire community, you're affected by it. You're affected by all the deaths, the suicides, the drugs, all the addictions. So all these layers of trauma. If you didn't even suffer from anything directly, you're more than likely still going to have 6, 7 ACEs, and even if you're brought up well. So you're highly prone to any addictions, and you're prone to all these problems. So going back to the medicine wheel, to completely heal, they found that when a person is lost, depressed, filled with a lot of traumas, they don't get a sense of purpose. A lot of times in prison right now, stats are extremely high for people that are incarcerated that didn't finish high school. If you don't have high school, it's nothing to do with your intelligence. The ACEs model shows that if you have high levels of trauma, it distracts you from continuing your education, continuing focus, and stuff like that, right? But in prison, you know, there's a lot of high percentage of incarcerated people that are didn't finish high school. So they don't. When you don't have a sense of purpose, you know, how is it that you're going to be motivated to go do jobs or to seek out things? And then when you have a lot of high levels of trauma, like depression, for example, depression. You know, people, sometimes our community members will say, like, how come people don't apply for jobs? You know, like, there's lots of jobs out here. Well, when you're depressed, you don't even feel like going out of your house. You don't even feel like doing anything. You don't even feel like associating with your friends. They say therapy and stuff like that. You don't feel like doing that. So how is it that you're going to be motivated to even go out and get a job if you're depressed and if you have a lot of multiple levels of trauma? So that's why people don't have a sense of purpose. Spirituality, that's why ceremonies, that's why all these things are working. Because again, if you don't have sense of, if you add a sense of purpose, it gives you that kind of encouragement. But spirituality will give you a sense of hope. And we need that. When you're depressed, when you have layers of trauma, addictions, you don't get a sense of hope. You burned all your bridges. You don't get a lot of support. You feel hopeless. Even if you're not addicted to any addictions or anything like that, if you come from a lot of trauma, sometimes it feels hopeless, you know, like because your community and just the way you're thinking and your depression thoughts. So when you start attending spirituality doesn't mean just going to sweat lodge or ceremonies. It can mean going to church. It can mean praying and doing the rosary. It can mean going for nature walks. It could mean anything that makes your spirit happy. That's a good thing, and that helps you to live in a good way. That's spirituality, you know, and connecting with people and learning about love, learning about how to love your community members and love yourself. That's spirituality, you know. So it'll give you a sense of hope. Emotional behavior will, you know, obviously, to stay balanced, you have to visit your family members, you have to visit loved ones, you have to visit your mom, your dad, whoever, you know, like to your best friend that you never saw in many years. As we're getting older, we tend to get stuck in these cycles. And these cycles is going to work, go home, make supper, clean up, watch Netflix, and go to bed. You know, like that's our routine. We don't even walk much anymore, other than to our rooms or to our cars or to the office. We're not even that active. You know, so all these things. You know, the emotional part is reconnecting with your family, going to community events, going to. So that's why when you're doing like hunting and fishing and all these things, this is gathering places. This is where you're going to meet people and engage, and that makes your spirit happy again when you're doing emotion. If you go to ceremonies, you get a sense of belonging, because when you have a lot of traumas, again, you're not going to feel purposeful. You're not going to feel a sense of hope, and then you're not going to sense of belonging because you feel isolated. Nobody understands. When you're depressed, nobody understands. You think that people can't relate to you or feel what you feel. It's very hard, you know. So you don't get that sense of belonging. So when you go to ceremonies, for Sweat, for example, once you do the ceremony, you come out of there, you all hug and shake hands, and now you're a brother or a sister. Now you get that sense of belonging, especially when you start going regularly. You become part of that family. And that gives you a sense of belonging. So now you're achieving that part of the medicine wheel when you get a sense of belonging. And then the mental part, you get a sense of meaning. So when you're trying to understand yourself, just like how we're talking these entire 2 days, we're going to be talking about all this stuff. You're trying to understand culture. You're trying to understand the importance of traditional healing, on-the-land healing, mental health, mental wellness. All these things we're trying to understand. You're trying to understand yourself, trying to get to know yourself better. The more you understand your traumas and where was in, then you get a better sense of meaning. Once you get a better sense of meaning, then you're able to move forward. And my colleague who's a psychotherapist, he liked to give an example of, it's like when you're trying to heal, it's like looking at a map, like at a mall. And you know your store, you know which store you want to go to, but it's impossible to find it if you don't know where you're at, what door you went into. You got to know where your X is at. So that's like healing. It's important. You know what wellness looks like and where you want to be, but it's impossible to get there if you don't know where you're at. So you got to understand your traumas, you got to understand your community, understand how all these things work, understand how cannabis works, drugs, all these things. Understand all these things so that you'll know where your X is at, and then you can be able to start your journey to healing. So that's how powerful the medicine wheel is, and when you understand that physical is connected to purpose, spiritual is connected to a sense of hope, emotional is connected to a sense of belonging, mental is connected to a sense of meaning. It's very, very important. And part of our program is we get a thing called Traditional Healer Fund, and we get some funding from the government. And that program, we usually help connect people with ceremonies. Sometimes we'll help them, we'll pay for like the beading and stuff like that, traditional healers, like supplies, medicinal supplies. So we use that program money to, and supporting camps and stuff like that. So, and anything that's happening in the community, sometimes it doesn't seem like we're present, but we're there in all of your guys' communities. Sometimes we'll be there in an obvious event, such as the mental wellness days we held. We went to every single one of you guys' communities in Cape Breton plus Buckingham. Jane Paul Center we're doing Thursday. So what we did was we did haircuts and just gave out some services, and we invited a whole bunch of different organizations. Usually everybody's numbers go up dramatically because when the community come out, they're like, oh, I didn't know about this service. I didn't know about JP. I didn't know about Nautica. And they start signing up for these things, and numbers usually go up because despite the fact that you think that people know that your services are there's so much services. No, every year we do this. Every year people are like, holy shit, I didn't know you guys do this. So, there's so much things that people don't know. So it's important to always showcase all these things and show our community members that there's a lot of services, and not just in our organization, but a whole bunch of different organizations. Another thing we do is in our communities is we try to, whatever your communities are doing, especially when it's around culture, mental wellness, of any sorts, if your guys' teams are doing something, sometimes, a lot of times we'll work with them. We always always collaborate, we work together, and I feel like that enhances not just our team, but your guys' teams as well. So whatever activities you guys doing, we always support and enhance those programs. Doing pretty good. I got a minute left. And these are just other programs and workshops, you know. I wanted to talk about this, even though I got only a minute. This is a 3 circles approach to crisis. Another part of our team, we're not technically a crisis team, but for 8 years now, we've been doing a lot of crisis work. We just naturally, and it's thankfully that our former team member was a psychotherapist, so we were able to do that. He was the trauma specialist for the province. And I ended up developing a 3 circles approach to crisis, and it contains outer circle, middle circle, and inner circle. And all that is just like a EMO plan, emergency management. You know, like similar kind of plan that you would have when you're approaching natural disasters and whatnot. Well, I developed one for crisis work, and what I do is I try to approach a community. If I'm invited, it'll have to be like the chief or the health center will have to invite me in. And then together we'll try to devise a plan and try to include certain key individuals, like, for example, somebody that has logistics for buildings, access to buildings, and food and supplies like that. Because our first approach is to develop, to open up like comfort centers. The middle circle is trying to tackle and address people that are directly impacted, such as, let's just say if there's an incident in the school, a student passed away. So one, the community is affected. We're going to try to set up comfort centers in appropriate places for the community. Then the middle circle is trying to address the more impacted people, such as teachers and students. So we'll do a grief session, emergency grief session with them, and some other activities. And then the middle circle, inner circle would be trying to get to the immediate impacted family members. So, and I can't just go up to a family member, hey, do you need our services? No, because this is a chaotic time. It's a crisis time. I can't do that. I would have to go to Annie. Annie, do you know so-and-so? And then can you help us let her know of our services and whatnot? And then Annie, because they're really close to that family, for example, if it's a in-law or whatever, then a person would usually know when is the right time to approach them with this kind of information. I call it the eye of the storm. You know, when you lose a loved one, it's chaos. It's just, you're just in shock. But there's going to be a moment where you stop crying, and then you'll be able to breathe a little bit, and you'll be able to talk to family members and focus. And that's when that critical information is useful. And we've applied that strategy. Works very well because people usually want services. You know, they're worried about their kids. They want emergency grief sessions. They want a sacred fire for the wake. They're trying to plan and think of these things. So it's important to reach out to these families. If it's emergency, like if it's crisis, like an accident or a suicide or whatnot, like Eskasoni, we had a suicide, and what we did is we applied the same approach, comfort centers, and then addressing the youth that are affected, and then we ended up doing with the family. Finally, I got to the family, and I got to talk to them. Then with the family and friends, I ended up planning a ceremony. So I took them out to the accident scene, and all this young person's friends showed up, all teenagers and their family members. And we did a pipe ceremony. We sang some songs. I put, because I had experience with a different kind of accident before, so I put like an altar and put a shell, and I gave everybody tobacco. So while we did prayers and sang songs, all the young people put their tobacco into this shell, and then I took some volunteers. Then after the ceremony, we took the shell and then we took it to the actual site. It was kind of difficult to get there, so that's how we concluded. And I told the young men, young youth, that now this is an accident scene. You know, we've been looking at this every day. We're driving by. The railing is damaged. The trees are broken, but just like this land, it's going to heal. And this railing's going to get fixed, and in time, you guys are all going to heal. And so there's a beautiful, beautiful ceremony because young people are looking at it as an accident scene. And to do this ceremony, it helps them heal and give rest to this area, you know, to give just to help the people to I don't know how to say it, but anyways, just to help them like get closure is what I'm trying to say. Get a sense of closure. And now they're going to look at this site as a memorial site. That's why he told me this is now a memorial site. It's not an accident scene anymore. And we got a lot of hugs from the young people saying we really, really needed this. So that's that approach. Tree Circle's approach to crisis. I approach it in a very similar way but it's adjusted based on the need. And I'm trying to further develop this, so it's going to be a template for all communities eventually someday, where you can fill out the key necessary people that you need to access this. Like, for example, every community has a different person that takes care of certain buildings, and the keys to certain buildings. If this happens on a weekend, who do we talk to get the keys? Every community has a different person. Every community has a different person that's going to pay for the food, like for the conference center as well, So it's going to be the chief, the band manager, somebody, So every community, we have to fill out the blanks on who are the key people, as well as outside organizations, as well as clinicians, therapists, whoever that's going to be supportive. Traditional healers, who are they? Put all those in each community, and that way, when crisis happens, because to me, I look at it as an emergency. I look at it as time is so essential, because if you don't put things in place as fast as possible, you could lose another person, especially if it's suicide. You could lose another person, or somebody. People could have a really, really hard time. So the quicker you put things in place and put things in motion, the quicker you can help our people. Anyways, that's all I want to say. Wala اليوم نغمة.
I think we're connected. Are they going to start that? Okay. I've yielded all my time to Buddy. Wasn't that wonderful? Buddy has so much wisdom. Good afternoon, everyone. My name is Donna Prosper. I'm the executive director with NADICA. I've been with NADICA, I'm going into my 28th year now. It's been a minute. This year, NADICA celebrated 50 years. Huge. And I worked under Joe for many, many years. And I think a lot of times, I was listening to the group that were talking about, from Dalhousie, talking about numbers, and there's a lot of questions about, just numbers. What numbers are here in Nova Scotia? So I was writing down notes and stuff and doing some doodling, and said, Weglis, he's like super good with tech stuff. So I said, let's put these infographics up there and let's give people the numbers and to see where we're at and what we're doing with treatment. Some may not know, NADICA is prevention, NADICA is treatment. In the treatment, there is Mi'kmaq Lodge Treatment Center, 15-bed facility in Eskasoni, and a 7-bed facility in Sispinacady. And for a national number, so this would have come from Thunderbird this year, and this would have come out of their data collection system from 55 of the treatment centers across Canada. 157 people from Nova Scotia, clients from community, whether they're living here in Nova Scotia or not, reached out to treatment centers this year. 157 is your number. Out of the 55 treatment centers that are across the country, we are a handful that are accredited. So we're accredited, so our board of directors is accredited for governance and management. And the treatment centers themselves are, so I don't miss anything here. The treatment centers themselves are accredited with culture, addictions, intensive treatment, and mental wellness. And I'm going to show you this as we go along. Out of staff of 28, 19 of our counselors are certified. They're certified through CCPC Canada and CACCF Canada. I'm going to bring up the next slide. the button? Green or red? I'm not a tech person. I'm so sorry. One of the biggest things that Buddy talked about was trauma. And everybody that we see coming into treatment, that is the problem. It's trauma. The substance abuse, whether it's alcohol, cocaine, marijuana, whatever that is, that's part of their toolkit for healing. So all of our stuff is focused on dealing with the trauma, culture, and language. So some of these numbers here. So you're looking at, I put side by side Eagle's Nest and Mi'kmaq Lodge, and I know Frida has reached out to the community as well recently and said, hey, this is where we're at and this is what we're doing. And we are trying our best, and the numbers are there. The work is being done. And Samo, Chief Norman, I'm going to throw you under the bus here for a second. So, you know, he has a new prevention worker in his community. And I remember this young lady, when she came into the treatment center, she's working with Wegatus, and they're doing some naloxone training, and I was like, oh my gosh. I remember she was 6 years old, and I was doing a workshop in her classroom. And congratulations to you that you have a wonderful young lady that's leading the way as a NADAP worker. So what you're seeing here, 156, that was 156 people who applied for treatment at Mi'kmaq Lodge, 58 for Eagle's Nest. So, and I know that's applications. So 110 between both were from Nova Scotia. 146 were completions. So out of the 214, some could have been referred to the virtual program, which I'm going to have Wegatus talk about in a minute. And you're going to be like, this is something that hasn't happening across the nation, and it's new. And we're getting a lot of support for it, and the numbers are there as well, too, to support it. Everything we do in our programming is strength-based. So we're starting from the ground up. And I think a big thing that we noticed, and Buddy talked about it as well, too, it's, you know, getting out on the land. We have a cultural therapist, we have clinical therapists, I should say cultural therapists. And that's the name that we use. It doesn't mean that everybody has to use that name, but that's what we use because it's just kind of grown with us. It's part of us as our treatment centers. The clinical therapists, so I was telling you, out of 146 people that completed treatment this year, and this number just popped right out at me when I was looking at my numbers. 84 of those 146 were on anti-anxiety medication or sleep medications. And I don't think we should forget about that, because those numbers are big. That's huge. And I know when because they were talking about youth. When we're talking about adults, out of the 214 that were coming in, 91% were there for alcohol. 74% was marijuana. 60% was cocaine. So in the reports that we do and that we gather together, we have a great big list of where the substances of choice that people are dealing with. So I didn't want to say anything there because I don't know. I can't speak on behalf of youth, but I can speak on behalf of what we know with adults. Let me just go through this a little bit. Okay, everybody says, with those numbers, 12,000%, really? How can that happen? 89. So what this is a combination of your clients. So you take your 146 clients and you keep multiplying it by the number of activities that they do. So what this is showing is that Mi'kmaq Lodge and Eagle's Nest, you take our contribution agreements, the money that we're funded for, this is how much extra work is being done in those treatment centers above and beyond what we are funded for. That is real. Those numbers are real, and that's what they collect. IS collects that. They want to see that, so they'll continue to fund us. Five non-operational days at Mi'kmaq Lodge. That was Christmas. That was Christmas break. Now, even during Christmas, we'll have somebody at each center on call to answer for emergency phone calls. Eagle's Nest was 6 days. I won't talk about the other programs here that Wegatis has done. So you had 9 inpatient programs at Mi'kmaq Lodge and 8 inpatient programs at Eagle's Nest with 14 aftercare sessions. So the aftercare would be the week in between programs. So there's always something going on. There's always, either you're doing inpatient programming, or you're doing outpatient programming, or you're doing aftercare. Could be AA, NA, and I know at Eagle's Nest, they have a really huge NA program that they do. We don't have that. We have AA, so everybody has their specialty. So that is one of the staff members, community members as well too, and she does an amazing job with that. I can't see that far. So, what's going on? Let me just grab my book here. So, so I'm going to flip to the next slide, which will cover the clinical therapy and the cultural therapy. But I just want you to see the map here. So what I've noticed since January is even, I know we're talking Nova Scotia here as well too, but we're seeing increases in requests for treatment coming from Restigouche and up in that area in Quebec and in, excuse me, Nashwashi and Sheshashi. And you ask yourself, why is that? A lot of these communities are more isolated, and Wegatis will explain that when he talks about this new virtual program that we've created. And just the word is getting out there that, it's a lot of good programming that's going on, and we're seeing people come back and repeat programs. So if somebody says, okay, well, I need to send somebody to a program, but 4 weeks isn't enough, 5 weeks isn't enough, you can do back-to-back programs. Having that break in between the programs is not a bad thing, because what we see sometimes is that you get into your 4th or your 5th week, then some people will start regressing. So once that starts to happen, you got to put a break on. Give them a break. Go home, come back, let's do this again. So we never tell people that they failed. You don't fail. This is not failure. If you lasted 2 weeks, good for you, and that's the support that we give to them, because that's a success to us. And if we see that somebody sometimes treatment can be harmful because they're dealing with a lot of trauma. So sometimes we have to look at, okay, we need to make some referrals here to get Buddy's team, for example. Somebody really needs to do some work with individuals. But this is what the treatment centers do. They really look at the entire person. And the assessments that we have, I know, Buddy, you talked about the ACE. We have what we call a DUCY. And a DUCY was made by Chris Musquash and from Thunderbird. He's from, where's he from? Northern Ontario. Anyway, doctor. He was here and he graduated from Dalhousie. So Chris, the assessment that we have looks at the entirety of the person, from their home life to their education to the substance abuse to where they're at right now, all of those things. So we really get an idea of where the individual is at. And then towards the end of the program, we get another snapshot of where that individual is at as well too. And we can see the things that the person has to work on. So when the exit surveys are done and being sent back to the workers, the NADAP workers in the community, some are social workers, it could be a community nurse. So when these exit surveys are sent back, there will be recommendations that are put on those exit surveys so that they can work with the individual and dealing with the aftercare. But aftercare is a whole different story altogether, because it's a hard thing to do. I think I covered everything on that one. So this is a whole lot of numbers. So the clinical therapists, clinical therapists deal with trauma. There's a lot of individual counseling that happens from both centers, and I'm just going to give you an idea of the numbers that we're talking about. So trauma group sessions at Mi'kmaq Lodge alone last year was 216. That's 216 trauma sessions that run about 2 hours each, with an average of 6 to 7 clients in each trauma group session. And then what happens after the session is over, clients that need to have one-on-one will have those one-on-ones. And they set that up. And the same goes for Eagle's Nest. And imagine, like, Eagle's Nest is half the size, but they still had 126 clinical therapy sessions, trauma sessions. And the one-on-ones, 61 individual sessions. But what we're finding, though, is if, I'm going to flip quickly here. Oh, I don't have to. So I told you I can't see. So the enhanced care supports for victims of family violence. So the only reason that the name is on this, what this is where we do our cultural supports from. And we did have funding under ISK, and that ended, and Dejagamic came along and said, hey, Donna, we'll help you guys out. And this is where that support comes from. So they've been on board with the treatment centers for the last few years, which I am so grateful. It's just, without this, we wouldn't be seeing the level of the people that are completing the programs that we are. Like, it wouldn't happen. It just wouldn't happen. So Mi'kmaq Lodge, out of 9 programs, they did 113 cultural group sessions. And what's funny, a lot of these group sessions take place on the weekends too. And you figure 769 participants in total. Those are big numbers. So there's something positive that's happening there. And the same with Eagle's Nest. And just remember, when we're looking at the numbers, it's half the number of people, half the number of beds in each treatment center. 193 participants for both. So the activities will include medicine wheel, seven grandfather teachings, use of sacred tobacco, dreams, teaching of medicine pouch and traditional medicines, medicine and tobacco ties, protocol for ceremony, sweats, ancestral fire, and ceremony for life. Group sessions will focus on family violence, domestic violence, relationships, cultural teachings, spirituality, 7 sacred teachings, sweats, drum making, traditional games, making talking sticks, boundaries, goal setting, self-empowerment, lateral violence, counseling, aftercare, planning, grief. And this, you got to think, none of this stuff is funded under our contribution agreements. None of it. This is because you have an organization that says, okay, we care, we're going to help you. And to see that this works together. And bringing on a recreational therapist this year, what a huge difference that has made as well too. Like that, were a lot of teaching of being outdoors and tools, just even for a dad. Like there was this dad that was we had a men's program 2 programs ago at the lodge, and this one dad says, and his ex said, he said, I just didn't know that it was okay for me to be happy, right? And you know, those are the things that we're finding, that between the recreation therapy and the cultural therapy, that the two together are really helping people to move along on their journey. So these are the real numbers. This is what's happening, and I wanted everybody to know that part of it. In 2020, when COVID hit, when the world was shook and we were all about ready to just pass out, and we're standing at Mi'kmaq Lodge, and the staff are standing in the hallway, and it's like, what are we going to do? What are we going to do? So this is my my lead into Wegatus here. And Wegatus was actually lost in Vegas at the time, trying to get on a plane to come back to Canada. The staff were devastated because they couldn't help their clients. And they were wondering, well, how are we going to help people? So we started off with something small, and I'm going to turn it over to Wegatus because it's turned into something really huge.
All right. Hello, everyone. My name is Wegatus Augustine. I live in Escazone, and I'm going to here talk to you guys a little bit about our virtual Aboriginal wellness program. So, March of 2020, what happened was COVID happened. Just because the world shut down didn't mean that addiction shut down. There were still addictions happening. We still had clients, and I remember hearing what Donna was talking about, you know, what are we going to do about our clients? We had 2 full treatment centers full with clients, and we're being told you need to shut down. Everything needs to close down. And so while everyone was closed down, we still wanted to support our people. Our people still needed something in relation to addictions of where they were, even during the lockdown. And so what happened was, you know, you think about, well, what do you put in a virtual program? And I remember Donna saying, you know, we have so much skill, you know, in our treatment centers that each individual has a set of strength that we can talk about and utilize within the virtual program. And so that's what we did. We went to each one of our fellow colleagues and our coworkers and said, you're really good at talking to 7 Sacred Teachings. You're going to do that video. You are very good at the medicine wheel teachings. You're going to do that. And so that's sort of what we split up within our program. And so what happened, I don't see it, but I remember when we were doing the video recording, luckily enough that I had training in terms of videography and video editing, that I was able to sort of, and I had the materials already and equipment to be able to do it. And so we'd bring in everyone and recording them. I'd be in like triple mask with the thing sweating all of everything when we're doing this. And so we were able to record that, and I was able to sort of, we decided on sort of the topics of that. And so we did the recording, I did the video editing, and we were able to build a 4-week program with this. Originally it started as a 3-week program, and we decided to add an extra week to make it a 4-week. And immediately, right, we started in June of 2020, we got like 10 clients immediately. Just to give you an idea of how many people still want to support in terms of addictions because they're home alone, which makes it even worse because you're by yourself and whatever. And so today, our virtual Aboriginal wellness program is a 4-week wellness program. It is a certificate. You do get one at the end of it. Originally, when we were first designing it, we were worried about the fact that we didn't want to make it too intense because you didn't want an individual who was going to be by themselves in the middle of nowhere with doing a program and be triggered. That is dangerous. And so when we were designing it and picking out the topics and the information that was going to be related to it, we had to make sure that it wasn't triggering and that it wasn't too intense for clients so that for safety reasons that they're able to take this information and utilize it. And so when we did that, we designed it, we used the strengths, and then we turned it into the 4-week program. And it worked really, really well. We needed to make it flexible, and we needed to be adaptable for the client to meet where they are, not necessarily where we are in terms of providing support. And so the way it's designed is that an individual, when you register, it's 4 weeks. We have, I think, 10 programs throughout the year. It's done via Google Classroom. We didn't want it to be like, oh, we're going to meet at 8:30 a.m. at Zoom, and we're going to do this programming. I didn't want that because I wanted it to be adaptable for the client when they're utilizing our services. And so what happens is the way the program works is that an individual, a video will be posted. It's more of like on demand. And so a video is posted at 1 p.m. every day. And it's related to different topics. And so it doesn't mean that they have to watch that video at 1 p.m. We have a lot of individuals who take our program who are single moms, single dads, people who work full-time, and people who can't go to treatment, whether they're on house arrest or whatever reason. I always tell people this when I'm talking about this program. Imagine you right now as a person, right now in this moment, and I said to you, you need to go to treatment for 5 weeks, you'd be like, what? I got a car payment, I got kids I got to take care of, I got work, I just can't take up and go right now. That's a reality a lot of our people face. And so this program allows them to sort of get their feet wet in terms of getting addiction support. Not only that, is that individuals, our brothers and sisters who live off reserve. A lot of our people live in cities. They live in Halifax, Truro, Sydney, PEI, Charlottetown, Moncton. They live off reserve. And so a lot of people, a lot of our brothers and sisters are able to take this program because they want ULNU programming while in the city. So they are able to use this program while living off of reserve. And so it's sort of evolved itself in a sense where it's moving in individuals who are leaving treatment. So say, for instance, in aftercare, if you have a client who is leaving treatment, but they're going home, that cutoff has been there for quite some time. You think, well, what are they going to do? They're leaving treatment, they've done all this hard work, and they're going back into their environment. How do we provide them support? So this virtual program allows them to continue programming after they leave treatment, which is something that we've never really had and something that we've struggled with. And we presented this in Ottawa, and so talking about the aftercare and pre-treatment options. So individuals who are nervous about going into treatment, they're worried, they don't know if they want to do treatment, because a lot of people have a lot of social anxiety, so they can't do group setting. It's all anonymous, they don't know who is who when you're taking the program. And so a lot of people use it as a pre-treatment option, they use it as an aftercare option, and individuals who can't go into treatment, they're able to utilize this program. The amount of referrals that we're getting is just staggering. Just to give you an idea, we did a lot of outreach. Thank you to the union for inviting us every year. And Buddy is right, our numbers skyrocket every time we do them. Just since June, the first week of June, we've gotten 92 referrals into our virtual program, which is skipping all the way into October. And so the amount of people that are utilizing this program is just staggering. And so sort of the topics that come with it that we talk about, we talked about, well, what do you put in it? We talk about cultural teachings, 7 sacred teachings, mental wellness, medicine wheel teachings, anxiety and stress, self-help groups, mindfulness, goal setting, and coping skills. Another portion of this is that we talk about, because we want to introduce all new sober activities. We have three videos with it that we discuss. One of them is learning how to bead. So we send them a learn to bead kit. We send them a package that goes with them. We send them a learn how to basket make. So we give them a basket making kit for them to do that. We send them a quill bracelet kit so that they can do that. You need a glue gun, so we send a glue gun with it. Introduce them to smudging. We have a smudging video, so we send them a smudge kit so that we have Dr. Lottie Johnson who opens the program and closes the program with a smudging ceremony. And so a lot of people, their first time smudging or first time having this medicine that they're able to utilize because they don't have a smudge bowl, they don't have sage, they don't have, a lot of people struggle to get that stuff. So they're very, very thankful that they get the smudge bowl with it. And so they get all of this information, we send them a kit, we mail it to them, and then they take the program. And so when we presented in Ottawa, we were talking about it, someone somewhere was like, we want to evaluate your program in terms of aftercare and pre-treatment options. And so this is where this image came out of. So we had an evaluator come in and sort of interview us, interview people who refer to the program, interview previous clients, and interview people who were in the program during that time. And the amount of information that we learned from it, that the gaps that it was bridging for our people who were struggling to get services was staggering. A lot of people felt a lot of self-connectedness to our culture, identity, and sort of being able to provide services that they normally wouldn't have been able to get. And a big shout out to our board who was always like, keep going, we'll support. And so this image, when we were being interviewed, discussing of how the program started. So if you see on the bottom is sort of where we are and are building our sobriety bundle, finding gratitude, and then because we do check-ins once a week, we call the client, and that enables us to be able to connect to them of where they need support, and that has been able to find referrals into other organizations that they need. Like, I'll give you an example. We had an individual who took our program, And when we were doing the follow-up, they were a single mother and they were struggling with resources, but they were coming because it was a referral through Micmac Family. And so I said, I know Micmac Family is able to provide this service through their prevention program. Do you allow me the permission to call them? Yes. So I connected them and I said, they'll be able to pay for this and provide that support. And so that's being able to provide that connection. That Learn to Beading kit that we gave, see on the bottom there, I had an individual who was taking the program, and when they were taking it, they were beading, their mother walked by and said, what are you doing? They said, oh, I'm doing my program. And they said, can I join you? And they was, sure. So they sat together beading while doing the program. And I was like, I was doing the thing, and I'm thinking, oh my God. And he's like, can I get another beading kit? I said, I'll give you as many beading kits as you want. Just keep calling me, Because these are sober, all new activities that they're learning and that they're able to provide, And so a lot of what people were saying as well, on the top, they said, it's okay to ask for help. A lot of individuals who were interviewed, they said that they didn't feel alone, that they felt inspired, that they feel trusted, that it's a chance, and can admit about needing help. And so a lot of interviewing, a lot of information about it. Although it is not a treatment program, it is more of a pre-treatment aftercare option, and it allows people to be able to provide it. Something that I'm always celebrating to talk about is that our program was became accredited in 2023, and it was one of the first virtual programs in the country to be accredited. So, woo! I'm super excited about that. So, clients do get, it's very simple to sign up. All you need is your full name, your date of birth, your band name, band number, phone number, mailing address, and email address. You might get a scenario where if you have a client who doesn't have access to internet, we made it where we'll connect with either their NADAP worker in their community or some sort of community member. And so a whole walk of life of people being able to take it for that adaptability. And to final, the last bit about that is, early on, I know they're not supposed to do this, but they did it. An individual who was in jail took the program through their social worker, that they were able to do it. And normally they're not allowed to do that, but I think it was part of the provincial thing. I don't think they could do it on a federal level, but the social worker went above and beyond to utilize this program for their clients while they were there. And so hats off to that individual. I don't know if they were allowed to do it or not, but I'm not saying who it was because we're going to keep that on the down low. So with that, I thank you all for listening to us. And if you have anyone who is interested in our virtual program, if you know of clients or any of your community members that may be working, I do have pamphlets. Chloe, you can raise your hand. Chloe is our virtual counselor, one of them. So thank you guys for listening.
All right, so thank you to all of these individuals up here. I think that the work speaks for itself, that we still have a road ahead and a lot of hill climbing, but again, our calves will look really nice when we get to the top of that hill. And to also acknowledge all the work that is happening, that there's so much stuff that is happening and things for us to celebrate and acknowledge, that it's not just the stories, but the data and the stats speak for themselves, that community continues to learn and acknowledge all of this work that is happening. And as we continue to work and bridge and build relationships across community with our health system, our Mi'kmaq organizations in support, as we move towards Dajigamik, that we move towards a place of wellness. So, with that being said, we have our mics, our mic carriers on the floor. If anybody has any questions, comments, thoughts, clarification, this is your opportunity to do it.
I think you broke it. There we go. Oh, another note I forgot to mention as well. I thought because COVID would be over, that the numbers would decline, that because it is a virtual program, it has actually remained the same and has jumped up a bit. So even though that our people, COVID is no longer sort of there, virtual services are still showing that they are needed. And if we can continue expanding virtual services, we're on board.
Any questions? Right over here, we have Chief Andrea, Regional Chief.
Hi, thanks. This was wonderful. That's a great presentation by all of you. I guess the question I have is, when I was chief, we had taken our prevention dollars out. So I'm just wondering what that inclusion looks like for the communities that are no longer on the board, and that would be through NADICA, and if that information, and because I didn't see stats per community, so I'm just wondering, what does that look like for each of our communities? It's just a curiosity question for me. Thank you.
I'm just going to speak about the virtual program really quick. I do have, we do still community outreach to your communities in terms of our virtual program and treatment. And so we were just there actually the other day.
Awesome.
Info booth. And I do have referrals for the virtual program. I try not to bring them up too much because it's sort of, there's at times when it's easy to identify people taking the program, but I know from the virtual program aspect that we do get a lot of, we get referrals from every single community in this room, and I know we've had people even from BC, Ontario, Alberta, Northwest Territories, all over the Atlantic. Every single new community in the Atlantic has taken one of our virtual programs from their community. And so I didn't get to bring it and show that, but the numbers that amount of people that are taking our virtual program is just staggering in terms of our UNO people wanting to get programming.
And it's on? Okay. The treatment centers work the same way. So we don't want to identify individual communities, but if somebody wanted to get information, there was a community recently that wanted their own information, and they gave me a shout, and I gave them the information that they were looking for. So it's not about being part of that NADICA umbrella. The treatment centers, there's 55 treatment centers across Canada, and it is a collective, but we stay when we're reporting our numbers, like that 110 that I pulled out that purposely so that we would know in Nova Scotia 110 people went through that program out of the 157 that they've identified across they could have come from anywhere in Canada, right? But 110 people from Nova Scotia completed that program. So if individuals wanted information, it's not a problem. I'm very giving, and we'll share that information.
Just continuing on as well, we continuously get calls from other communities asking for education for their communities, even though they may not be part of NADICA prevention. We've never said no to our brothers and sisters who've requested any kind of education. I know I've done workshops in almost every single community in the past few years, up to Bahankeg, where people requested it and said, hey, we're having a struggle with this. Although that's part of the prevention programming, we're like, well, we have a workshop that we do, and we try to provide that support. Like I know right now, I was requested just recently to go to Bahankeg and do a workshop on how addiction hijacks the brain for their youth. And we never say no to communities who say, especially with the resources that we have in terms of education and treatment and our virtual program, because in the end, we're all trying to help our people, and saying no or saying, being like, no, just because of that or whatever. No. Our idea is to try to make the best support for our people as much as possible. And with that, we're not saying no.
Well, Allen, thank you.
So you said this program's flexible, like in regards to hours, when a person can take it. And you have facilitators also, right, that go through. So how is that flexible? Like, what are the hours of that flexibility?
So what happens is, say for instance, if we, like just last night, I got an email at 11 p.m. asking a question or commenting on within the program, because that's when it's convenient for the client to take the program. We'll respond the following day between the hours of 1 and 3, and then we'll do the follow-ups. So we'll do follow-ups on Mondays, and then we'll say, you know, how did you like the week? What videos did you stand out? Is there anything you want to talk about? And that gives us to connect. And then there's individuals who only want to communicate via email. They're like, I don't want a phone call. Do not call me. We'll communicate over email. And I'm like, all right, we'll do that. Because we want to be adaptable to their needs, not necessarily our needs in terms of, you know, it's more of meeting where the client is and where they are in terms of support that they need. Because I don't know about your communities, but in Eskasoni, pre-COVID, internet wasn't really that good. It was really, really bad. And so we had a lot of people who were taking our program wait for their children to fall asleep so that they wouldn't lag them while they're playing video games. And then them getting mad at each other, you're lagging me, oh my God. And they're trying to do a program, you know, that benefits them, but so then they wait for their children to go to bed, sometimes at 12 o'clock. And so they're able to take our program when they can, when they're able to do that. And sometimes people will save the videos for the whole week and only watch them on the weekend and, you know, do it that way. Whatever is for that. And then we've had clients where they couldn't, you know, they needed to expand it a bit more, like they needed 2 more weeks to complete it, and we'll do it. We'll call them. We'll be like, all right, we'll expand it for 2 weeks for you. We'll try to meet them where they are.
Well, Lonnie, first of all, I like the presentation, buddy. A lot of key words you use: sense of belonging, being worth, and part of the community, you know. These are words we need to work on as, well, I was holding it so long, I'm trying to reformulate it in my head again. So, first of all, I know what all of you do, and you work hard at it. You do a great job. But I just gotta put my, it's, when you deal with individuals, I always compare metaphor, saying that person is just a tree. And you look at the bigger picture, the forest, Nubuk, what's been done to us. And I was thinking when all this time, compared to cancer, right? Cancer is a very, it's a hard word to accept when you have it, right? So getting treatment and prevention and all that when we look at it. So looking at addiction, we always want to look at what causes as prevention of addiction. I have to say, it's the years of how we've been treated, colonialism done to us. As a nation, we were a thriving nation prior to pre-contact. And when they took over everything from us, put us on reserve with, I don't want to use the words I'm thinking of, it's just very little. And the policy, the Indian Act, the assimilation paper, and keeping us pinned down in our communities, which causes numbers to go up in all your where's body? The wheel, physical, mental, spiritual, and I forgot one more, what was social. So when you have all that affected by what rest of, foreign powers are doing to us, and then we try so hard to stay alive or be on top, but they won't let us. And so, bottom line, I'll make it short. Bottom line, we need to be firm on our rights and able to do what the Creator set us to do, be everything you have to be in what's provided by the Creator, meaning honor our tree, have access to our forests, access to our waters and minerals, and be thriving again. This is would be the answer to a lot of. I know I don't want to. We keep working at trying to get ourselves. What my grandfather said was, "You are rich when you're healthy." We need to be doing stuff our own. One more. I hear elders when they talk to me. He said, in Mi'kmaq, it's hard to translate, but I'll try. Medellin, how are you? And they'll say, busy, ankidasi. And what that means in English is, I'm busy thinking. After they all did their time of work and retirement, and they're just thinking now. So that's important. Like, how do we get ourselves busy? I know you talked about a lot of crafts in your programs, and these are medicine. And I know this guy believes in it, because when he makes a drum, he talked about that making a drum is it's so. All the words he used, like patience, discipline. You're at ease. This is the cure for all of our ailments. It's able to do stuff that causes, just like making a drum, that feeling. Okay, I'll stop. Thank you.
Yep. We're going to go
Hi,
to the back
is
of
this
the
on?
room.
Yeah, okay. Hi, I just had a question. So if medication was part of somebody's specific healing journey with their addiction, do you guys have safe connections made in community to help bridge those gaps, like in specialty areas, for example, like addiction psychiatry?
So, it's on? When an individual is referred to treatment, they fill out a medical and list all the medications that they have on there. So what we've been doing in the past couple of years is that we'll reach out to the referring physician and make sure that we use the word stabilized, but again, it's for lack of a better word. So a lot of treatment centers won't accept clients that are on benzos or antipsychotics. They just won't do it. But there's a couple of First Nations treatments in this Atlantic area, including Rising Sun and us and Eagle's Nest, Mi'kmaq Lodge, Eagle's Nest. And we will work with the doctors. We will work with the clinicians one-on-one. We will get letters from psychiatry, from the clinical therapist, from the doctor that says that they are going to work with that person once they go back. Because that's a huge gap, and it's very, very dangerous, especially when people go back and they're left all by themselves and they don't have a follow-up. Not every single community has an ADAP worker. Some communities just don't have the funding for it. ISK has not, like I always complain about this, ISK has not increased those contribution agreements in 30, 40 years. You know, inflation is not going to do it, that small little 2-3%. So we don't lose people. This is what we found helpful to us, so that we know that we're sending people home safely. And that's really important to us. I hope that answers your question.
Thank you.
I just have a short one. All the work you guys are doing is wonderful. It's great. It's well needing in our communities. You guys deserve applause. Really, it's hard. I worked in addiction myself. I worked in Indian Brook at the treatment center of Eagle's Nest for 12 years. And I've seen 9 suicides in 1 month. 9. So I know what you guys are going through. But I guess my question is, we all know we're trying to get to the goal, to the top. But we're leaving out the number one part, I believe, is the youth treatment center, somewhere in Atlantic Canada. Our leaders hear this. Take it to the federal government and look for dollars for our youth, because those are our tomorrow's leaders. And if we're not helping them, we're just doing this here just for pastime to pay these guys to make the buck. We need youth treatment center. I don't care if you take the Lodge, I don't care if you take the New Brunswick one, the Eagle's Nest, and use it as a pilot project, just to say we're going to try this out, to see how it works for a year, and take all that data and to present it to the federal government to move everybody here. Everybody in this room got children that are addicted by some kind of a drug or some kind of sickness. We know that. My family, I had it so bad and still have it today. I don't want to get into the details, but look, guys, you guys are politicians. They're sitting around here, chief and councilors. Push for a damn treatment center. That's all I have to say for youth.
Hi, I'm Stuart. I'm from Weroma. I suffer from bipolar, and I suffer from alcohol and drug addiction. I've been sober for 15 years, you know, and I just got a question, and I've already mentioned it before a couple of months ago about Suboxone and methadone clients. I know I have clients that are wanted to go rehab, and they're always rejected. And I'm just got a question: how far are we from accepting clients?
So the biggest problem with it is that in order to have people in your program safely, and that the rest of the people that are in the program are safe as well too, because, you know, you're talking about it's very dangerous, right?
Yes.
We're not funded. We tried. 2016, 2017, we wrote the proposals for the opiate replacement therapy to get it.
Yeah.
We did not get it. We didn't get it for Eagle's Nest. We wrote it for Eagle's Nest. We wrote it for Mi'kmaq Lodge. And like what I was saying about the contribution agreements as well too. And those in positions here as executive directors know exactly what I'm talking about. They're not increasing that money. So they chose 2 treatment centers in the entire Atlantic Canada. One was the Healing Lodge, and the other was Rising Sun. You have to have a medical model in order to do that. You have to have the nurses in place. You have to have the pharmacy that is willing to work with you. You have to have all of those things in place that are working hand in hand. And when you take it from, when you're taking from the community, the pharmacies and the nurses and stuff that are in the communities, that's the funding for that particular community.
Yeah, but I'm just worried about them because they're people too, you know, like,
yeah.
you know, they need help.
We don't have the people. We don't have doctors and nurses. We don't have the money.
Are you guys still pushing it?
The thing right there where she just hit it. I stood up because right now the doctor part. Chief and council are not the doctors as well. Okay.
No.
So here we are trying to look at it, and I feel the same thing where he's at because I see the difference. I don't quit on people. I don't. But seeing them today, somebody could be knocked down. Where's the hand to help them back up? Why kick them while they're down? That's my heart feeling. Because it's very hard seeing people to that point or getting a call at night. If somebody says they're going to do something at night, my wife, hey, what? I got to go. Why? Because somebody just said they're going to do something. Taking them out because of this program. Learning that right now, when I first got in here, the stuff that we end up doing, I didn't think I was signing up for that. Backbone support in your circle is another big thing.
Thanks, bro.
Then you have to push for those programs.
And
So-
I got another suggestion, you know, if anyone's listening. When you graduate to a rehab center, you do a 35-day program. That's not enough. When you're sent back home, you know, and you get to be bored. And I've been advocating a building for long-term recovery program for our people. You know, maybe like a 6 months to a year program where they can settle and grow from it. You know, from my experience, honestly, I had a real hard time sobering up, you know, and I'm not what you call it. I'm ashamed of my past, but I've grown, you know, and I've moved on. You know, I'm just here to not to create trouble or anything. I just want to help our community and our people. Thank you.
And
just
so,
wanna add to
thank you. Just before we go to the next speaker, we're going to have one more speaker. Then we'll go to the breakout sessions. I know there's a break there, and I'll look to you guys. You guys could take a break or grab things on the way to the breakout sessions, and then we can finish up our day. I do want to address the last discussion. I know you're next.
Yeah,
but thank you, and this is why we're here, because we have the leadership in the room. We have technical people that are working very hard to expand the programs, to build support. And so our leadership, and I know when I personally went to most of the communities, and mental health, wellness, addictions, and the legal system was the top priority with every chief and council. And so to come together to talk about this, to come together to hear the technical people about all the good work they're doing, all the hard work we're doing, and the challenges that we have. So looking to leadership to come together to say, let's get this done. Let's act as a government, because we know it's a governance issue. We know it's the Mi'kmaq of Nova Scotia. It's the Mi'kmaq that need to govern ourselves, that need to push the government to do the right thing, because they haven't and they're still not. So I truly appreciate the conversations today. And then, like I said, there's stickies on the note, sticky papers on your tables. We want to hear from you. We want to find out strategies, what will work in your community. What is the challenges? What are the challenges in your communities? I think we all have them. We all have the same ones, a little differently. No one is being given up on, and it's how do we get there? How do we make that reach? So I'm looking forward to the breakout sessions for everybody, and we will go there in a minute. We do have one more speaker, and then I'll explain to you the breakouts.
Yeah, good day. My name is Blair. I've been out of addictions for 5 years. Injuries, personal injury. But the thing is that you guys are all doing a great job. Commend you. Wake up every day. You help our people. But the thing is, we have to work on the gaps. We're missing, I still see the gaps. You know, I started detox in 1990. I worked there. Me and Story Gold. So we have gaps. We have detoxes. That's one of our gaps. We have a treatment center for IV drug users. That's one of our gaps. Crack users. That's one of our gaps. You know, and but these guys here, we're talking about people on Suboxone, but we can refer them. We can refer them to Rising Sun. We can refer them to Tobic. You know, even right now in Nova Scotia, we don't got that. We don't got a treatment center for Suboxone. You know, so we have to refer out. We have to refer out to New Brunswick or Tobic. You know, and that's, but no one should be turned away. And I agree that you guys don't turn anybody away. That you can refer out, or you can find a center that will help them. You know, and I still see the gaps, but that's why we're all here today, to work on the gaps. You know, to fix the gaps. Because the gaps, even though we fix them perfectly, there'll still be gaps.
Yeah.
So, you know, it's, you know, like again, I commend you. I commend chief and councils. I commend your work. it's never ending. But, we work together, we'll get solutions. Thank you.
Great. Thank you.
Thank you. I just want to.
Go ahead. Okay.
I just want to say, it's quite obvious that the gap that you're talking about is usually revolves around funding, and a lot of our people in our communities for years volunteered, trying to help our people in whatever crisis situations, and then organizations came forward and then people, in their jobs try to help people, such as our wellness teams and NADICA. But the biggest problem is we need, like Reg was saying, we need facilities, and a youth facility is one of them. We probably need our own drug facility. But here's the problem, and it's always money. And like Donna mentioned, is ISK, and the government. But the problem lies in I don't know, maybe this is already looked at, maybe this is already talked about, but just in case it isn't, I'm going to mention it, and is data collection and data sovereignty. And what I mean by that is our team will collect, for example, Donna just showed lots of numbers. Same thing with our team. We show a lot of numbers. Michelle's team, we show a lot of numbers. We send these to the government. Government looks at it. Okay, they dealt with this many clients, and then they probably just need this much money. They give us this much money. So what we need is to start looking at data differently. And what I mean by that is when I look at a client, my team, yes, we're looking at somebody, and social workers know this. Social workers are trained to handle a client based on their training, a client that has 1, 2, 3 traumas. But like I mentioned in my talk, all new people, if you're growing up on community, you have 7 to 10 ACEs, 7 to 10 traumas, Whether you think so or not, you're somehow affected directly or indirectly. So when we're working on a client, yes, we're dealing with this one trauma, but to even get to that trauma, we uncover another layer, another layer, another layer, another layer. So we got layers and layers and layers and layers of trauma. That takes quadruple the amount of time and energy just to focus on this client. On top of that, we have to help them navigate the system. So we'll have to advocate for them for finding housing, apartments or welfare. They're trying to, they don't know how the system works, so we have to connect them with certain people, the hospital, the doctors, just like what Donna was mentioning. We have to help them connect with all these things, trying to create a well-being, a wellness for this individual. So it takes enormous amount of work and effort just to work with one client. And then on top of that, there's no 4:30 for us. I meet clients at the grocery store. I meet them at the gas station. So all day long, every day, I meet clients. And yes, I set boundaries, but you can't just close off clients. You have to talk to them and do your best to help them. So there's no off switch. So that means us as workers and the clients, I'm just guessing, the data that we sent to the government, let's just say if I dealt with 100 clients, it's actually probably times 4 or times 5. So 500 is probably the accurate number, or if you're working with 1,000 clients, it's 4,000 or 5,000. So then the government should in return look at it and give us the appropriate funding. Therefore, we can hire an army of staff and facilities to accommodate our people in the right way. This nickel and dimes that they give us is not enough. It's like equivalent to giving us a cup of water, trying to put out the house fire, but at the same time we have to mow the lawn and fix the fence and paint the step, and on top of all these things. So that's what equivalent the government is giving us in terms of information and data. That's all I just want to add.
Thank you. So Grand Chief, we have one more speaker. We'll hear from you, and then we'll go to the next speaker. Then we'll look at closing up to the breakout sessions. Grand Chief? Is it on?
I don't know. I just want to have one sense, my grandfather's teachings. I know we talked about teachings. He said, you have a strong faith in the Creator and a new medicine. So when you use the word in new medicine, it means nebisukti ginu, us treating ourselves. And this is just an example. Our people doing what's supposed to be done. So at the end, when we finally get everything done, it'll be us.
Yep.
Thank you.
Exactly. Exactly. And that's what we're hoping for, and we're hearing that today. One last question, please.
Hi, my name is Lucinda Gugu. I don't work there now, but I did work at Wamiko Guthrie Health Center, and working with the ORP program, I noticed like a lot of gaps. I had clients like not want to go into the program because as soon as we go through the program or we start the process, they're told they have to have like so many therapy sessions done and all this stuff, and it would just throw them off. So by the time they like get the therapy sessions done, they kind of get dug out at that point, and we lose them in the process. Like I've had the same client try to get into the program probably like 4 or 5 times, and literally I've kept losing him within the process of trying to get him in the program because he each time didn't meet the criteria. So that's a big gap I noticed.
Great. Thank you for that. It's really great that we can sit in a room and talk about the strengths and some of the gaps, where we want to go, where we want this journey to take us, and how to get there. How do we want to get there? So I look forward to the breakout sessions, to hear your words and your continued questions, because these are the ones that we need to focus on. And like I agree with Grand Chief 100%, it's about governance. It's about the Mi'kmaq taking control and ownership for the Mi'kmaq and doing what we need to do. Now, I'm going to look, I don't see Craig here, but he taught us a word. We go through language lessons, and it was thinking Mi'kmaq. So I'm going to look at Grand Chief. Was it Midasi? Midasi? Mi'kmaq Midasi? And it's thinking the Mi'kmaq way. And so that's the way that when we talk, have our conversations and look at filling these gaps, sticking together and thinking the Mi'kmaq way. How do we support each other in the Mi'kmaq way? So with that, really, I want to say thank you to the panelists, and I know Nick has a small token of appreciation for them. But when you're doing your breakout sessions, I want you to remember this. So our people, our technical people, our people who are here on this stage that are in the centers today, let's not forget about them. Because when we talk about mental health and wellness, they need support too, because it's 24 hours, all day, all the time, right? So definitely a big hand and a big thank you for what you do and recognizing what they do. And as we're building our mental health, wellness, and justice system, look to support your service delivery people as well, because you don't want to have them go through the same thing. You want to hold them up as well. So with that, thank you guys very much. Go to look to the breakout sessions. If you look at the front of your cards, you all have a color. So the color is your breakout rooms. There's a couple of here and a couple past the front desk, the lobby front desk. I know we're on break. We're running a little bit behind, but what I'm going to ask you to do is go grab something and go directly to your room. Don't come back here. Go directly to the color coordinating room that you have on your front desk, and then we'll come back to close up at 3:45. 3:45. Your coordinators will help you go back, so please go directly to your rooms.